in.
Webinar now, broadcast all attendees. So is it working now?
Yes, ma'am.
Okay, I'm going to do a little, why isn't it?
You want to go ahead and mute?
Yeah, hang on. I need to be sure my working, if possible. So why am I not able? Oh, here we go. So let me be sure these are working.
Tonight, we begin a week-long.
You are.
Okay, the participants are in, Ms. Stevens. I'm going to get started now, if you can mute. Good afternoon, and thank you for attending the 2020 Behavioral Health Symposium. We're happy to host this event as a virtual conference because we care about your health and safety, but we also understand how important it is to provide relative and robust continuing education for Louisiana healthcare professionals. For quality purposes, all participants will be muted during this presentation. If you would like to submit a question to the speaker, please use the Q&A feature in the virtual platform. This session is accredited for 3.5 hours for the following: social workers, licensed professional counselors, addiction specialists, peer support specialists, psychologists, nursing will receive contact hours, and AMA, PRA Category 1 credit. Full participation is required to receive credit and will be monitored throughout the session. You will receive an email from Women's Foundation with detailed instructions on how to claim your credits and access your certificates. Additional information is available in the digital event booklet you should have received. Ms. Julie Stevens and Dr. Cataldie have no financial disclosures. None of the members of the symposium's planning committee or any session moderators have any financial disclosures. This session is presented by Ms. Julie Stevens, MPS, ACPS, ICPS, and Dr. Louis Cataldie. Ms. Stevens has been in the addiction field for 35 years. She is an advanced certified prevention specialist and was a licensed chemical dependency counselor for 20 years. She has served as Director of Prevention for the Texas Commission on Alcohol and Drug Abuse and training specialist for the University of Oklahoma's Southwest Prevention Center, and most recently as Executive Director of Life Steps Council on Alcohol and Drugs. She is currently Chair of the Prevention Specialist Committee of the International Certification and Reciprocity Consortium. Ms. Stevens serves on the Texas Certification Board of Addiction Professionals and is chair of the Prevention Subcommittee. She has a bachelor's degree in psychology from Baylor University, 15 postgraduate hours in clinical psychology, and a master's of prevention science from the University of Oklahoma. In addition, Ms. Stevens is an adjunct professor for the University of Oklahoma College of Liberal Studies. She teaches core courses for Masters of Prevention Science degree, including Foundations of Prevention and Prevention Across the Lifespan. Our second speaker for this afternoon is Dr. Louis Cataldie. He's a native of Louisiana and received his medical degree from Louisiana State University Medical School in New Orleans. He has extensive clinical and administrative experience in addiction medicine and is a diplomat of the American Board of Addiction Medicine. He has been in the field of addiction medicine for over 30 years. His first encounter with the recovery process began on June 28, 1978. Dr. Cataldie has developed and served as medical director of several successful recovery programs for both adults and adolescents. Dr. Cataldie was a consultant to the White House on adolescent inhalant abuse during the Reagan years. Dr. Cataldie previously served as medical director for the Office of Addictive Disorders for the state of Louisiana. He is a published author and is long recognized as an expert in the field of addiction medicine. He is also a sought-after public speaker on the diseases of addiction. In 2005, he was appointed medical examiner for the state of Louisiana and the Incident Command of the Family Assistance Center for Hurricane Katrina. He was in charge of the recovery and identification of deceased victims of Katrina and for finding the location of over 26,000 missing and displaced persons. Upon completion of that mission, he returned to the field of addiction medicine. He is actively involved in community service and serves on the Eye Care Advisory Board. He has served as Louisiana State Medical Society Governor's appointee to the Addictive Disorders Resource Authority and to the Child Death Investigation Review Board. Dr. Cataldie has served as medical director of the Louisiana State Board of Nursing and is currently an addictionologist consultant for the board's Recovering Nurse Program. He has also served as medical director of the Physicians Health Foundation of Louisiana. His current addictionology practice includes providing detoxification, evaluation, and treatment on both an inpatient and outpatient basis for people wishing to recover from the brain disease of addiction. Ladies and gentlemen, I present to you first Ms. Julie Stevens and then Dr. Louis Cataldie. Thank you.
Well, good afternoon and thank you, and hello from Austin, Texas. I'm social distancing here, but would love to be with you there, and I admire you all who are survivors of the recent hurricane and hope that all is well with you there. We will be looking at, I think until 2:30 is my portion. We'll be looking at opioids, the making of a crisis. I got interested in this because I was wondering how all this happened, how this crisis happened. So our objectives today, we will be looking at, some of the various forms of narcotics and opioids and the physical and psychological effects of opioids, and then some data, and then actually the events that contributed to our current crisis and how things were promoted by pharmaceutical companies. And then looking at what our nation is doing in response to the crisis and what we can do as community. And I will be showing several videos during this time. I hope this all works technologically. If not, somebody flag me down and tell me if you can't hear or see. So I'm going to start with a sort of a news report on some of the problems of the opioid crisis. So let me start with that.
Tonight, we begin a week-long series looking at the opioid epidemic, a serious issue around the country. The CDC says each day, 91 people die from overdoses. 91. Senior correspondent Rick Leventhal tells us where we are right now and the surprising way this country got here.
On any given day, the Warwick, Rhode Island Fire Department's Rescue 1 rolls on a dozen calls. Traffic accidents are routine, and so are overdoses on opioids like heroin, fentanyl, and oxycodone.
And we spray this up into the nostril.
Rescue Lieutenant Henrik Dunleavy shows one of the methods for administering Narcan, a life-saving drug for opioid OD. He's seen a dramatic uptick in addict rescue calls in his 17 years on the job, and sometimes saves the same people over and over again.
They're this close from dying, and then you get them back with Narcan, and they're awake, and they're talking, and they're like, oh, no, I didn't do anything, and then finally they admit, oh, I was doing heroin. Okay, well, don't do that again. And then, like, next week you come back, and there they are again. And you hit them again with Narcan, back. I'm like, what are you doing?
The worst drug-induced epidemic in U.S. history.
Bertha Madras is a neuroscientist on President Trump's opioid task force. She says the crisis traces its origins to a pair of studies in the 1980s, including this one in the New England Journal of Medicine, which declared addiction.
Oh dear, what did I do?
Was rare for patients treated with narcotics. Pharmaceutical companies launched aggressive campaigns promoting powerful meds like Vicodin and OxyContin. There was movement to name pain as the fifth vital sign, and physicians began writing hundreds of millions of prescriptions based on what Madras calls poor science.
Nobody had done long-term studies on treating chronic pain with opioids. There was nothing in the literature.
You can't overstate the pressures that were put on young physicians in the late 80s and early 90s to treat pain, not just adequately, but aggressively treat pain.
Dr. Michael Dacey is the president and COO of Rhode Island's Kent Hospital. 3 ODs arrived by ambulance in the hour or so we were there, 2 more the next day. Dr. Dacey says the medical community was misled, but it shares responsibility for this deadly scourge.
You had a combination of people fervently trying to do the right thing at the same time as these more potent, newer forms of narcotics like OxyContin came along that were marketed initially as being not as addictive. Turns out they were at least as addictive. So you had this perfect storm coming together, and as physicians, we own a piece of this.
In upstate New York, the opioid epidemic forced Syracuse Behavioral Health Care to dramatically expand its facility.
We serve a couple of hundred patients. Now we're serving over 900. And that isn't enough. We're literally bursting at the seams.
The opiate treatment program distributes methadone and other drugs through dosing windows with nurses and counselors on duty around the clock. Because CEO Jeremy Klemanski says if addicts don't get immediate treatment, they will die.
We don't debate whether or not someone with chest pain would likely die if they didn't get into an emergency room. We don't debate whether a diabetic left untreated would really die of their diabetes and when. But for some reason in this sector of healthcare, sometimes there are people who want to debate those things. And the reality is the debate is over.
The number of people who die in the U.S. from drug overdoses every year is staggering. 52,000 in 2015. That's more than car crashes and gun homicides combined. In fact, opioids alone kill 91 Americans every single day.
The pain that pill caused me is a trillion times worse than any pain I would have endured, I'm sure. Go on.
Nathan Wendelowski got hooked on Oxy after surgery and eventually moved on to heroin, in and out of rehab for 10 years.
Why didn't it work? Why did the first time, the second time?
I didn't think I could do it. I just kind of was like, I loved it. It was my everything. I loved it more than my family, more than my job, more than my friends, more than my girlfriend at the time.
He's been sober 4 months and says the substance abuse program at Butler Hospital saved his life.
How do you know that you're not going to go back again?
I take it one day at a time.
Yeah.
And I see people dying all around me, people very close.
Yeah.
I have more people died that I know than I have fingers and toes.
Right before I left, the nurse or the receptionist said, ooh, honey, wait. I bet you're in pain. Let me have the doctor write you a prescription. And I'm like, a prescription for what?
Danielle Amaral says she got hooked when she was still a teenager after she went to the dentist to get her wisdom teeth pulled. Years of abuse later, she's taking another drug, Suboxone, which cuts her craving for Oxy and helps her live a sober life.
You think of addiction, you think of like a street drug and crack houses and scary places, and it's not. It's not. They're everyday people like that had no idea.
Nathan carries a clipping of a lost friend as a reminder of what could happen to him. There will likely be at least 50,000 similar obituaries this year. In Providence, Rhode Island, Rick Leventhal, Fox News.
So some newer data, and you may hear some data quoted in some other videos that I'm going to show that said 91 people die every day, but the latest data that we have from 2019 is that 130 plus people die every day from an opioid related overdose, and this is from the National the HHS, Health and Human Services Administration. And so we can see from this data, you know, people who use heroin for the first time, people who misuse prescription opioids for the first time, and then the number of deaths attributed to overdose of synthetic opioids and all. I was looking for the one that had the cost. I don't see it on there. You know, interesting data, updated data, and we can look at this as the cost to us, to our society for the opioid epidemic. So let's take just briefly, you know, look at what are opioids. You know, the term opioids comes from a Greek word for stupor, narcotics. In general, you know, we're used to calling the drugs narcotics, and I think the DEA calls them narcotics, and law enforcement does, but it is opium and opium derivatives and semi-synthetic opium. So that's what we're looking at for what narcotics are. And there's 3 levels. One is, you know, all natural opiates, opium, morphine, and codeine. And then there's semi-synthetic opioids, which are synthesized from the opium products. And these are heroin, oxycodone, hydrocodone, and hydromorphone. And then totally synthetic opioids are made in the lab. And so fentanyl, methadone are the total, are entirely made in the lab. What do they call them on the street? You know, you probably heard many of these things. Smack horse, black tar, hillbilly, heroin, oxycontin, sipping syrup. So these are some of the common street names that you probably have heard. And they come in many, many different forms. They can come in tablets and capsules, patches. Fentanyl sometimes comes in patches for medical uses, powders, chunks, you know, black tar heroin, white heroin. White is pure. It comes from Asia. Black tar and brown heroin usually come from Mexico, South America. And they can be swallowed, smoked, sniffed, or injected. So many, many forms and many, many types of opioids are available. And basically, you know, we have opioid receptors in our brains because we have natural opioids in our bodies. So they bind to the natural receptors that we have. When a person injects heroin or morphine, it travels really quickly to the brain, and it's concentrated in the ventral tegmental area, the nucleus accumbens, and so you can see here the central brain, but these little turquoise specks are all the opiate receptors and where opiates can reside. Caudate nucleus is involved, the thalamus is involved. So opiates bind to our natural opiate receptors and are concentrated in the area of the reward system, and that's the purple area there. But the action of the opiates on the thalamus is what contributes to their ability to produce analgesia and pain relief. And so action is a little more complicated than, you know, if you're looking at cocaine, because there are 3 receptors involved. There's a dopamine terminal. There's another terminal, which is possibly contains another neurotransmitter, GABA. And then there's the postsynaptic cell. So the opiates bind to the opiate receptors. And this is green here on the slide, on the neighboring terminal, and then sends a signal to the dopamine terminal to release more dopamine. So that's how it acts. And then the increased release of dopamine increases the activation of the dopamine receptors, and that causes the production of CAMP inside a postsynaptic cell, which alters the normal activity of the neuron. And so as a result, opiate actions in the nucleus accumbens are increased, and impulses leaving the nucleus accumbens activate the reward system. So continued use of opiates makes your body rely on the presence of opiates in order to get the reward feelings that we like, and just, you know, basically rewarding normal behaviors. So the person who is addicted to opioids and using it is no longer able to feel the benefits of natural rewards, food, water, and sex, and cannot, function normally without the drug present. If they don't have the drug, then there's withdrawal. If they do have it, then there's tolerance and very often increase in the use of it. So I want to show you another video that's really going to explain how this all works. It's what I call, and he calls, science-y. So a lot of science going on in this one, but it's a very good video.
We're continuing our in-depth look at the class of drugs known as opioids. How do they work? What's the science behind them? That's the topic of this week's Healthcare Triage. This episode and our entire opioid series are brought to you in part by the generous support of the National Institute for Healthcare Management. We all know that analgesia, or pain relief, is the intended use of opioids like morphine. But before we can talk about how these compounds reduce pain, we need to discuss the physiology of pain perception. Let's start with some biology. The brain and the nervous system are made up of cells called neurons. Each neuron consists of a cell body, which runs the neuron's activity. The cell body has a number of dendrites which come off of it. These are short fibers that receive signals from other neurons and transmit them to the cell body. Also attached to the cell body is an axon, a long fiber that takes messages from the cell body and sends them to other dendrites and from there to other cell bodies. Axons can also end up in other tissues like muscles, transmitting commands to them as needed. When nerves talk to each other, it's called neurotransmission. They do this by releasing chemical messengers called neurotransmitters across the spaces between cells, which are called synapses. The chemicals are released from the axons and are picked up by specific molecules called receptors in the dendrites. There are different receptors all over the body that send messages to your brain when they're exposed to stimuli. There are temperature receptors that tell you when you're feeling something hot or cold. Mechanical receptors let you know when you're touching something or something is touching you. There are even receptors that detect changes in pH. When stimuli are interpreted as being noxious, meaning that they could cause damage to our tissues, specialized receptors called nociceptors send signals to our brain. Nociceptors are located throughout the body, but we mostly think of them as being in the skin, the walls of organs, and deep within other body tissues like muscles and joints. So if you've ever mashed your finger with a hammer, splashed hot water on yourself while cooking, or rolled your ankle while playing sports, you can thank your nociceptors for sending a message to your brain all about the dumb thing you just did. We commonly refer to this message as pain, but nociceptors are kind of like the first leg of the journey that a pain signal takes to your brain. When we encounter noxious stimuli, like touching a hot stove, an electrical signal is sent up a primary afferent neuron to a part of the spinal cord called the dorsal root ganglion. There, electrical current causes a release of neurotransmitters that pass the pain signal from the primary afferent neuron to a secondary excitatory neuron. There are several neurotransmitters involved in pain signaling, but the major players are glutamate and substance P. The message is then sent up the spinal cord to different parts of the brain where it's interpreted as pain. One area of the brain that receives the signal is the thalamus, which helps give context to the message. The thalamus relays the message to the hypothalamus and limbic system, which help us learn from our pain and avoid touching hot stoves in the future. A downside to these parts of the brain receiving pain messages is that they can modify our behaviors and emotions about pain in ways that can be disruptive. Afraid of getting shots because of a traumatic childhood experience at the doctor's office? Yeah, that's probably not the nurse or pediatrician's fault. You can thank your limbic system for that one. So what does all of this have to do with opioids? Well, the cool thing about opioids is that they inhibit the pain signal at multiple steps in the pathway. They work in the brain, the spinal cord, and even in the periphery. In the brain, opioids have mood-altering effects, cause sedation, and can even decrease the emotional response to pain. Opioids block the signaling from the primary nociceptors to the secondary neurons. Opioids also work on neurons that descend from the brainstem to the spinal cord that function to modulate pain signals. Those descending pathways have fibers that either amplify or inhibit pain signals being sent to the brain. Opioid compounds suppress the fibers amplifying the signal and enhance the fibers that inhibit the signal. There's even evidence that opioids can work peripherally to decrease activation of primary neurons and inhibit immune and inflammatory responses to noxious stimuli. The fact is, opioid medications are so effective at treating acute pain because they attack it from every neurological angle. Let's get even more sciencey and technical for a second and talk about how opioids work with the neurons in the spinal cord. We'll focus on the area where the primary neuron is passing the pain signal to the secondary neuron. Remember, the space where the neurons meet is called the synaptic cleft. The influx of calcium ions causes the release of neurotransmitters into the synapse. Those neurotransmitters will float across the synapse and then bind with receptors on the postsynaptic neuron. This initiates a chain of events within the secondary neuron that further propagates the pain signal to the brain. There are specific opioid receptors on both the presynaptic and postsynaptic neuron. When an opioid compound attaches to a receptor on the presynaptic neuron, it decreases the amount of calcium ions that can enter the cell, ultimately decreasing the amount of excitatory neurotransmitters that are released into the synapse. Opioids binding to their receptors on the postsynaptic neuron function to decrease the response to any of the neurotransmitters being released from the presynaptic neuron. The end result? Less pain. But wait a second. Why do our nerves have receptors that respond to a compound that miraculously diminishes pain? After all, it doesn't really make sense that mammals would evolve a specific receptor for the sap of the poppy flower. Humans have known about the analgesic effects of opium for millennia, but we wouldn't really be able to explain exactly why we had opioid receptors until the 1970s. It turns out that we have a built-in or endogenous analgesic system that modulates pain signals. These endogenous opioids, like beta endorphins, enkephalins, and dynorphins, are collectively known as endorphins, a name derived from endogenous morphine. See what they did there? So things are going to get super duper sciencey here. The beta endorphins, enkephalins, and dynorphins interact with different opioid receptors to varying degrees, but one thing they all have in common is the tetrapeptide sequence tyrosine, glycine, glycine, and phenylalanine, or TYR, GLY, GLY, PHE. This sequence is really important because it's needed for the endogenous opioid to interact chemically with the opioid receptor on a neuron. If this is hard to visualize, think of the opioid receptor as the car's ignition, and the tetrapeptide sequence is the key. If the key fits in the ignition just right, then the opioid receptor will be activated and cause a series of changes in the neuron that decrease the pain signal. Opioid drugs and medications take advantage of this structure-activity relationship. They bind to our opioid receptors in much the same way that endogenous opioids do, but with much more powerful consequences. There are three types of opioid receptors: mu receptors, kappa receptors, and delta receptors. When activated with an opioid agonist like morphine, hydrocodone, or heroin, they will all produce analgesia, but each one comes with an unpleasant suite of side effects that we often associate with opioid use. Kappa receptor stimulation is associated with hallucinations and dysphorias, an overwhelming sense of dissatisfaction, anxiety, and restlessness. Delta and mu receptor agonism can cause respiratory depression because opioid stimulation in the midbrain suppresses the body's ability to appropriately detect carbon dioxide levels in the body. This can cause a person to simply stop breathing for a period of time. Other unpleasant side effects of opioid drugs are sedation, urinary retention, nausea, vomiting, dizziness, and really, really, really bad constipation. One might argue that the most catastrophic side effect of opioids is tolerance, meaning that higher and higher doses are required to get the same level of pain relief. The exact cellular mechanism behind tolerance is unclear, though there are many plausible theories. In any case, opioid tolerance is the harbinger of physical dependence and addiction, and that's the topic of next week's Healthcare Triage.
Yes, it was very sciencey, I know, but important information and on how, opioids work in our brain and in our body. And he mentioned several effects that opioids do have on our body, and let's talk about a couple of those. Effects on the brain, they can cause daytime sedation or sleepiness on our brain, but also there's a risk of depression. Heroin can elicit drowsiness as well, with abusers frequently experiencing what they call nodding off or falling asleep if they slip in and out of consciousness. Long-term use of painkillers is associated with major depression. Patients using painkillers in excess of 6 months have 50% more greater chance of developing some sort of depression. And then in the respiratory system, then this is the most critical thing that they do. They can cause major respiratory depression and slow breathing and result in death. And so if you have somebody you think is overdosing, the main thing you need to do is to support their breathing to make sure that they can breathe, because this can be fatal. They also have effects on the digestive system. He talked about how they can lead to constipation and also nausea and vomiting. Nausea occurs with many users of opioids, along with sudden uncontrollable vomiting, and so there might be medication need for that. It also affects our nervous system. It can lead to development of hyperanalgesia, a syndrome that means that we are increasingly sensitive to pain. Also, it's associated with psychomotor impairment, slowing the physical movements. So nervous system effects as well. And the immune system, they can inhibit our immune response and our immune system. And then the liver, there's liver damage can occur because very often things like Vicodin and Percocet have acetaminophen in them. So, and then if you also add alcohol to the mix, then it certainly does more damage to the liver. That's a very risky situation because it decreases the liver's ability to process, the toxic combination of ethanol and acetaminophen as well. So that's a big problem. And then another issue besides just the effects on the body is if people inject opiate. Because street heroin can be cut with any type of impurities, and these contaminated particles travel through the body, become trapped in the capillaries, and can result in clots in the capillaries, cut off blood flow, and cause damage to various organs. So intravenous administration of opiates also lead to inflammation, infections. So it's just, the risk of injecting, there's also HIV risk, hepatitis C, chronic liver disease, lung infections, tuberculosis, and all those are risks for people who inject opiates. And so we do have treatment for drug overdose, and that's naloxone or Narcan. This actually blocks and interferes with the absorption or the linking in the brain with the actual opioid with the receptors in the brain. So I'm going to show you a little bit about how to demonstrate how to use this, because this is something that now, we as interested individuals do have access to naloxone.
So my name is Sarah Meckin, and I work for the Addictions Bureau at the Boston Public Health Commission. We're going to be talking about Narcan and overdose prevention today. Narcan or naloxone is a life-saving medication that can be administered nasally via a spray that can actually reverse the effects of an opiate overdose. So this is one full dose of Narcan. These are all the 3 pieces that come in each dose that we give out at the A-Hope the Needle Exchange program. And the way that you put this together is super simple. I'm going to take the applicator, and I'm going to take these 2 yellow pieces off that you see here. So the first 1 and then 2. And you'll see that there's a tapered end here and an open end with a needle, and that will allow this applicator to access the medication. The second thing I'm going to do is I'm going to take this vial of medication, and I'm going to pop off this cap. It'll be either red or purple, and I just grab it underneath. I put my fingernail underneath, pop it straight off. And then on the inside, you can see a rubber grommet. What I'm going to do is I'm going to put the two open ends together like this, really gently, and twist until I start to feel a resistance. Then I'm going to take the atomizer, and this turns the liquid into a spray and allows the liquid to go up through the nose and enter through the mucosal membranes, and then enter and pop the opiates off of the receptors in the brain. So I'm going to take this atomizer and twist it on the top like this. Now this is one full dose, and it's ready to go. So what I'm going to do is I'm going to go ahead and administer it in a spray, half up one nostril and then half up the other, the whole thing. How we train people to respond in case of an overdose is to first recognize the signs of an overdose. And there are really three fundamental things that we teach people to look for. Is one, we say, look for blue lips and fingertips. The second thing that we teach people to look for is whether or not the person is responsive. If I, verbally ask someone, are you okay? And they're not responding to me, my next step is to go physical. So I'm going to give them a shake, a really gentle shake. If they're still not responding to me, the last and final way that I'm going to know if that person is overdosing or not is I'm going to do a sternum rub. So I'm going to bring my knuckles up like this on my hand, and I'm going to rub hard and fast on someone's sternum or on their breastbone or underneath the nose if you can't get to this area. If they're not responding to me when I'm doing that, I know that there's a problem. The third thing that we look for, and this is really the key around opiate overdoses, is respiration. So if the person is not breathing or has labored breathing or has a sound in the back of, we call it the death gargle in the back of someone's throat, it means that the body is actually struggling to get oxygen into their system. So we know that those three signs together, and we're sure that that person is starting to overdose. So with Narcan, the reason that we're able to give this out to folks who are either actively using or family members or people and loved ones of folks who are active drug users is that this medication has no adverse side effects. All it does is takes the opiates off of the brain receptors and allows the person to start breathing again. I don't have anything on my system right now except a lot of caffeine. Now, if I push this up my nose or administer this to myself, all I would get is a runny nose. There's no indication, there's no contraindications, there's no problems with administering Narcan.
So, this is how to administer Narcan. It's available to the general public, like she said, to family members, to users, to recovering folks. And so, that's a good thing. But if you do come upon somebody or you're with somebody you suspect has overdosed, first of all, you call 911 and tell the operator, where you are in the location. And don't worry, there's a Good Samaritan law in place in most states, and you won't be suspected or arrested for any reason, but mainly, get some emergency help for that person. But this is interesting on how to administer it. So let's talk about the prescriptions and the problems and why we're even in the situation that we're in right now. I have some new data and I have some old data, so I'm going to show you, a combination of what I was able to find. And we know that the amount of opioids prescribed per person is 3 times higher in 2015 than it was in 1999. And we're looking at that by by county. This is just a graph, and this is shows the dark or the black areas are the counties that have actually the most amount of opioids prescribed per person. So MME is actually a morphine milligram equivalent, and it's a way that they are calculated the total amount of opioids, and they account for differences in the type and the strength of the drug. And so it's sort of a measure, of what somebody is prescribed. And you can see the black counties, and I'm looking at Louisiana, and I'm looking at parishes in Louisiana, and I see several areas that are black, and these are the ones that have prescribed the most amount of MME per person in that county. So, California's bad, Nevada's really bad, and then Tennessee. And so there's a lot of areas, Maine for some reason, but there's a lot of areas that have very, very high prescribed opioid drug rates. And where you live matters, actually. This is some information about, you know, healthcare providers that began using opioids in the late 1990s to treat chronic pain. And, you know, it's about access. It's about, are you in a county that, where you can get care? You know, healthcare providers should be providing safe and effective pain treatment, but, you know, where you live does matter. And some very, very large counties and in very, very small counties are the ones that have most prescription rates of opioids. And states matter as well. You can see this is a number of opioid prescriptions per 100 people in this. And so the dark purple ones, which includes Louisiana, are the states that have the most opioid prescriptions per 100 people. And the dark purple ones say that this is 96 to 143 prescriptions per 100 people. So some of these states prescribe more than one prescription of opioids per person. So it's pretty stark and pretty interesting, though, to look at the differences between states that have lower numbers of prescriptions and then states that have higher numbers. We've done better, you know, we've done better. This just shows, you know, a trend in opioids overall and then high dose opioids that have been prescribed. This is from 2006 through 2017, and you can see the peaks around 2011 and 2012. It actually leveled off then, and it's been declining since 2012. But the amount of opioids in these MME morphine milligram equivalents prescribed per person is still 3 times higher than it was in 1999. There was a 19% reduction in annual prescription rate between 2006 and 2017, and the declines in the prescribing rate since 2012 suggest that healthcare providers are becoming more cautious in their prescribing practices. However, there's still 58 opioid prescriptions written for every 100 Americans. You know, that's a lot. I had surgery recently. I had a prescription. I, you know, used Oxycontin, I think, for 3 or 5 days, and then that was it because, you know, I knew of the dangers, and I was given 7 days worth, which is good too. So more than 17% of Americans had at least one opioid prescription filled with an average of 3.4 opioid prescriptions dispensed per patient. Generally, like I said, it's in very large counties or large towns or smaller cities. They're usually prescribed more rate, higher prescription rate to white residents, higher numbers of dentists and primary care physicians per capita. These are counties who have more people that are uninsured or unemployed, and more residents who have diabetes, arthritis, or a disability. And so these are the counties with the higher prescription rates, the characteristics of these counties. So where you live really does matter in this situation. This is an interesting data. This is where do people get their opioids? And these are non-medical users, you know, people who use it and they don't have the prescription for it. And you can see most the prescriptions are given to them by a friend or a relative for free. Then there's prescribed by either one or more physicians, stolen, you know, bought from a drug dealer. So these are the sources of prescription opioids among non-medical users. But interesting that they're given by a friend or relative, you know, and that happens frequently. I live in a retirement community, an active adult community, And, you know, do you have any oxycodone? Do you have any hydrocodone? Because I've run out, or I'm having pain or something. And, you know, so there's a lot of sharing of prescription drugs, which is makes me very dismayed. But there's been 3 waves actually of opioid overdose deaths, first starting in 1999. And this is when an increase in prescription opioids in the 1990s. And so there were a lot of overdose deaths at that time period in that wave. And you can see that's the purple line that involved actually prescription opioids. So that's when it started. The second wave, which is orange, I guess, began in 2010, and that was rapid increases in overdose deaths involving heroin at that point. And then the darker blue is wave 3, which started in 2013. And this was a significant increase in overdose deaths involving synthetic opioids, particularly those that involved fentanyl. You've heard horror stories about fentanyl. The market for illicitly manufactured fentanyl continues to change, but you know, fentanyl is very often found in combination with heroin, counterfeit pills, and then sometimes cocaine. So these are the 3 waves that we've seen, and you can see right now, this is up to 2018. We're looking at tramadol and fentanyl, either prescribed or illicitly manufactured. Very, very high amount of overdose deaths involving those 2 things right now. And then we also have an interesting, some interesting data here, 2017 and 18, which looks at overdose death increases. Now, the states, including Louisiana, that are the dark red are stable. They haven't had any significant increases. And then the light red are decreased, but the very light pink or pale red, these states have shown an increase in overdose deaths since in 2017 and 2018. So that's some data. Let's look at current events and what's happening and the actual impact it's having and how it happened. I want to show you, this is about opioid addicted babies. Every 19 minutes, an opioid addicted baby is born in America. Oh, wait, let me go back and hit the play button.
JC was 6 months old when her mother, Jennifer Frazier, who was struggling with an addiction to painkillers, accidentally gave her a fatal dose of methadone. We met Frazier at a Florida prison where she's serving up to 15 years for her daughter's death.
He put me away for a really long time. And I'm already suffering from the loss of my kid every day. So no matter what kind of punishment you give me, I'm punishing myself. And people make mistakes.
Reporter Duff Wilson led a Reuters investigation into cases like JC's and found many other examples.
We identified 110 cases since 2010 in which children died after being sent home with mothers who had used opioid drugs during their pregnancies. Now, there's a federal law that's supposed to help and protect those children. It says that hospitals are supposed to notify Child Protective Services about the newborns, not to remove them, but to provide services and to check out that their home is safe. But we found that system is broken. A number of times, the hospitals did not notify social services even when the baby was going through drug withdrawal. And in other cases they did, but social services didn't do as much as the law says they should to help, and the child died.
As an opioid and heroin epidemic sweeps across the U.S., an alarming number of babies are born dependent on the drugs their mothers were taking. This video was taken in a hospital in West Virginia. The child's experiencing the painful symptoms of withdrawal, which can include severe tremors, violent spasms, and hypersensitivity. After 2 months of withdrawal, the boy in this video recovered enough to be sent home with his mother. In 2013, there were 27,000 drug-dependent newborns, 5 times more than a decade ago. The Keeping Children and Families Safe Act, passed in 2003, is designed to protect these infants, alerting authorities when a baby is born drug-dependent. But the Reuters investigation discovered that social services never hear about thousands of these newborns. We asked former Congressman Jim Greenwood, who championed that bill, about our findings.
It says that people are not following the law. It says that the states are not abiding by the law. It says that the hospitals are not abiding by the law. The doctors are not abiding by the law. And in many instances, the social service agencies that are there to protect children are not doing their job either.
Frazier says she wishes social service workers had intervened in her case.
Whatever happens, I just hope that from sitting here today, whether everybody in America judges me harshly or not, that maybe some kind of program will be made to where another little JC will be saved.
I show you this because I just wanted to make you aware that it's not just the people who have an opioid use disorder or who are addicted, and some of them overdose and die that are affected. We also have these opioid addicted babies that are affected as well. So more than just, when we think about those who are addicted and are using. So how did this happen? This is what fascinates me. Very, very interesting. This is, and you can read this on the screen. I'm going to basically give you a history and a background. This is actually the 5-sentence letter that was sent to the New England Journal of Medicine as a letter to the editor, not as a journal article, which had been peer reviewed and replicated, all those things that you have to do in order to get your research published. But this is just, was published in 1980 in the New England Journal of Medicine in their, letters to the editor. In 1980, Herschel Jick, who was a doctor at Boston University, he had a database of hospital records that he used to monitor the side effects of drugs. And he was interested in looking at addiction, so he had a graduate student that was working for him, and her name was Jane Porter, and he asked her to calculate how many patients in his database got addicted after being treated with pain medicines. And so he wrote this letter, and you can see, he said almost 12,000 patients who received at least one narcotic prep, only 4 cases reasonably well documented of addiction who had no history, and patients who had no history of addiction, and he didn't think much of it. But it did attract a whole lot of attention, because what happened was it began to accrue citations. And when you write some research paper and you cite something, and it's a journal article, but this was not. But it began to accrue citations, and its findings, just began to mutate as it went on and on. They had only looked at hospitalized patients in the hospital who had, were not addicted, who had a narcotic, and that detail, the fact that it was a hospital setting kind of got lost in the push to prescribe opioids to patients at home, which is a different scenario. Purdue Pharma, which makes OxyContin, started using this letter's data to say that less than 1% of patients treated with opioids became addicted. Think about that. Less than 1% of patients treated with opioids became addicted. So pain specialists routinely cited it in their lectures. And, there were other studies, but basically this Dr. Jick just was mortified that his letter to the editor was used to do this. It was called, one paper called it an extensive study, another paper called it a landmark report, and then Time Magazine wrote in 2001 a story entitled Less Pain, More Gain, and it called it a landmark study and said that there was an exaggerated fear that patients would become addicted and to opioids, and that this is basically unwarranted. This fear that people would become addicted was unwarranted. And so that's where it all started, from this 5-sentence letter to the editor in 1980. And then it just rolled and rolled because these pharmaceutical companies totally, took it out of context and exploded. Now they say, on their website, the New England Journal of Medicine's website, where you can research it and find it back in the 80s, says that, the letter should be taken as, it's been uncritically cited, so it's not evidence that addiction is rare. But this is how it started. And so this is what just floors me, is that, 5 sentences in 1980 and then totally taken out of context and exploited. So I want to show a little bit. So this is actually the Time magazine, part of their articles, that they say 2001, many physicians concede now that patients have been under-medicated for decades and they're suffering needlessly. It was concerned that big doses of opiates could depress respiration, but a large part stem from exaggerated fear that patients would become addicted. This fear, which continues to hold sway over American medicine, is basically unwarranted. A landmark study published in 1982 followed 12,000, and this is, the 5 sentences, but it's called a landmark study. So, you don't see cancer patients running around robbing shopping malls to support their habits, was written as well. And so Time magazine got in on the hype as well. So I want to show you a little bit of this.
Here's a scary fact. In 2014, 47,000 Americans died from drug overdose. That's a new record. But if you peel back the numbers, many of these Americans are not dying from illegal drugs. The main killer is not cocaine, meth, or heroin. Instead, totally legal opiate painkillers were the biggest cause of overdoses. How did we get to this point?
So in the 1990s, doctors were under a lot of pressure from advocacy groups, the federal government, to treat pain as this really serious medical issue. And there was pretty good reason for that. There were about 100 million Americans suffering from chronic pain.
The undertreatment of pain is a major public health problem, whatever the cause. Some end up shuttling from doctor to doctor, desperate for relief.
Under this pressure, doctors turn to opiate painkillers, highly potent drugs that bind to receptors in the nervous system and reduce pain messaging to the brain. And one reason doctors turn to opiate painkillers is because drug companies like Purdue Pharma said that they were safer and less addictive than other painkillers on the market.
We now find that these medicines are much safer, much more powerful, much more versatile than we used to think, and we feel that they should be used much more liberally for people with all sorts of chronic pain.
Yeah, that wasn't true at all, that these drugs were safer than the other ones on the market. And in fact, Purdue Pharma ended up paying hundreds of millions of dollars in fines for its false claims later on.
The damage had been done, and by 2012, physicians wrote 259 million prescriptions for opiate painkillers, enough to give a bottle of pills to every adult in the country. Since opiate painkillers are so addictive, millions of patients got hooked on the drug. And as use proliferated, many patients overdosed. In 2014, nearly 19,000 drug overdoses were linked to opiate painkillers, about 40% of all drug overdoses recorded that year.
So yeah, here's where it gets really ugly. The doctors began pulling back these prescriptions, but what that actually ended up doing is that because these painkiller addicts were already using and addicted to opioids, they just went to another opioid, heroin. People who are addicted to painkillers are 40 times as likely to be addicted to heroin. Since 2000, heroin overdoses are up by 500%. More than 10,000 people died of heroin overdoses just in 2014.
The government is finally responding to this whole problem. The Obama administration, along with local, state, and private efforts, have significantly increased funding for prevention and treatment programs. But fundamentally,
Okay, I'm going to stop here because this is where the video goes into the glories of marijuana for medical purposes. But I just wanted to see you know, that gives the history and the background of how this was promoted by pharmaceutical companies.
Here's a scary fact.
I won't go there. So this is just some data in 2017 looking at all drug overdose deaths. It says that the total was over 72,000, but broken down, opioids, it looks like we're involved in about 49,000 overdose deaths. Synthetic opioids, about over 28,000. Heroin, over 15, almost 16,000. And then synthetic opioids, almost 15,000 as well, and then cocaine and other ones. So you can see, I wanted you to see the numbers there and how they collect those numbers and how many deaths were attributed to each category of opioids, pure opioids, synthetic, and then semi-synthetic opioids as well. And then so what do we do about this, you know?
We have about 10 to 12 million Americans who have been put on long-term opioids. The best available evidence is telling us that they're not doing well. Many have had a decline in their function, and their pain has not improved. Maybe their pain has gotten worse.
So very, very high doses of opiates can actually produce pain. So instead of making pain better, they actually make pain worse. Most common chronic pain conditions that are currently treated with opiates probably shouldn't be treated with opiates at all, other than possibly for 3 days of an acute attack. So for example, a back sprain injury, use opiates for 3 days, get moving again, and then stop completely, just like the CDC recommends.
The question we're often asked, if not opioids, what then? And we need, as physicians, to have lots of what then answers.
We know they do much better with simple things like exercise,
Yoga and acupuncture and massage, behavioral, physical therapy, spiritual support for a person to re-navigate their life and to take control over this sensation of pain. You have to take care of a complex problem with a complex solution, which is not going to come in the form of a pill.
So I like this because the question is, okay, what then? You know, if we can't give or don't want to give or afraid to give opioids because of their addictive properties, you know, what do we do? And that's what they're looking at in this very short little film clip. You know, what do you do? They mentioned behavioral therapy, yoga, physical therapy, exercise, acupuncture, massage, and spiritual support. So you know, if you're looking at medical assisted treatment, MAT, you're looking at a combination of those things as well, so that people can be treated without using addictive drugs and addictive opioids. So you know, that's where we have to come back around to and begin to think about what can be done now about this crisis. Yeah, we looked at the history and saw how it happened and what all it does to the body, but now what? But I'm going to pause here and do a little something that sort of bothers me when we talk about issues like opioids and vaping and all. Because to me, the perspective, if we want to look at what's, you know, what the perspective to me is, you know, an issue is we still need to look at alcohol. Alcohol still is killing more people has more deaths in this country than heroin and opioids. We're still looking at, and this is a little parentheses here that I'm throwing in here, and then we'll get back to looking at some solutions for our opioid epidemic. But I'm just saying, I am just saying that we need to continue, our focus on underage drinking and alcohol, and the number of deaths that we experience in the United States related to alcohol. And we know that the CDC says, too much alcohol can harm your health and shorten your life, and talks about excessive drinking, deaths among working age adults, and not to mention the cost of our society that alcohol-related deaths cause. So that's my little 2-slide parentheses there. Let's not forget about the issue of alcohol and the problems that we're having there. So what now? What has the federal government done? I think President Trump created a commission on the opioid issue, and they came out with an opioid strategy. It has 5 points to it, and it's basically a framework. And they have given this information and charge to their agencies to implement these strategies. So the 5 strategies include, number 1, which I'm glad to hear because I'm a prevention specialist: improve access to prevention, treatment, and recovery support. Services to prevent health, social, economic consequences associated with the opioid addiction and enable individuals to receive long-term recovery. This is about access to care, actually. Well, besides the prevention side, need to be sure that people have geographic access and monetary access, insurance, access to treatment, whatever is needed there. So this is the first strategy is access to treatment, prevention, treatment, and recovery services. And the second one is to make sure that the naloxone and the Narcan are available to people who are likely to be around those who overdose, any high-risk population, family members, people in recovery, active users who, and I can tell you that some of the other data that I've looked at, I think when they first wanted to make it access to the general public for Narcan and naloxone was like, well, then people are going to use it, are going to do their drugs, their opioids, because they know they can have access to naloxone, and that has not happened. There hasn't been an increase, and so the general public is able to have access, family members and all. So that was the second one. Third, they want to strengthen public health data reporting and collection so that we have more real-time data, because data is like 2 or 3 years old by the time we get to it, to inform public health response to the epidemic as it evolves, which is good. They also, the number 4 is to support cutting-edge research that advances our understanding of pain and addiction, and actually look for, something, a substitute that is not addictive, substitute pain reliever that is not addictive, is one thing that they're looking for. And this, the agencies that are involved in this include the CDC, Federal Drug Administration, and NIDA, National Institute of Drug Abuse, are involved in the research component here. And then the 5th one is let's look at pain management and evidence-based care and some of those other things we talked about earlier about what do we need? Well, we need, physical therapy, massage, acupuncture, behavioral therapy, and those kinds of things. So let's look at that to manage pain instead of going to opioids. So those are the 5 things that the government says that's part of the government's strategy. The 5 things that are part of the government's strategy for reducing the opioid epidemic problem. But let's go a little bit farther down and look at grassroots coalitions and what can community coalitions do to address the opioid epidemic as well. These are things from this group called International City and County Management Association. The first one is basically looking at creating community coalitions to work together across sectors. So the sectors are very diverse, and if you worked in a coalition, you know all this. This looks very familiar to you, but we're looking at employers, youth workers, bringing together families, faith community leaders, schools, administrators, teachers, public health, law enforcement, pharmacists and doctors, so the medical community as well, and join together to provide education, disseminate information, create action plans, and conduct education throughout the community, so the community is aware, raise awareness in the community about the particular issue. That's where data is important at a community level as well. And the second one is to have a place for safe drug disposal. We have Drug Take Back Day, but this is about having 24/7 access, and these drop boxes can be in police departments, as long as there's some sort of a supervision by law enforcement. So collecting any drugs that you don't need any longer, that you're not using, to get rid of those, so you don't have to, certainly don't want to flush them down the commode and ruin our water. Also, they encourage the establishment of drug diversion task forces dedicated to sharing information on what's going on in the community, on what type of investigations they're looking at prescription fraud, anything like that, and illegal trafficking of prescription medications. So that's what the task force would be doing in the community. They also recommend providing the Narcan, the naloxone, to first responders, so that that's available when they come across somebody who needs that as well. They also recommend drug courts, and what drug courts do is they kind of like reduce some of the burden on jails and create case management services for people who are fighting opioid addiction as well. So this is a good economically, it also helps free up jail space. And create referral programs through law enforcement agencies. What this talks about is allowing people to go in and voluntarily look for help. So if there's a list of some sort of resources in the community that's posted in the law enforcement agencies, people can go in. And then they also encourage the counties or the cities or whatever jurisdictions or individuals to donate money toward the cost of people's treatment, so they can have access to treatment if they don't have those types of resources. Also, disseminating information about state laws, Good Samaritan laws, drug overdose amnesty laws, allow people to call 911 without being afraid of it. Having, this is good, the drug prescription drug monitoring program. So this is a database that discourages doctor shopping, so people don't go from pharmacy to pharmacy or doctor to doctor to try to fill their prescriptions. Hosting community mobilization events to put tools in the hands of the community is important. So there's a toolkit that Hazleton provides for communities called the Toolkit for Community Action. And then also, basically these 9 things are what you need to do to create a community coalition. engaging key stakeholders, those influencer people, and those community champions who are interested in working at the grassroots level to reduce overdose deaths in the community. What can be done? Well, the federal government is educating healthcare providers. They're providing states with resources. They're improving access to treatment and recovery. They're increasing access to naloxone and those kinds of drugs. They're tracking opioid trends. So these are part of the 5 strategies that I talked about a little bit earlier, and supporting research about pain management and addiction and other alternatives to pain management. What can states do? Maximize your prescription drug monitoring programs by using real-time data so that pharmacists can actually go and look up somebody's name and see if they have gone across the street to try to refill or fill a similar prescription. And I know that it's important also for you guys who live on the border, because people can go into the next state and fill prescriptions. So, you know, if you're in Slidell, you might want to check with PMP in PDMP in Gulfport, Mississippi. If you're in Lake Charles, Orange, Texas. If you're in Shreveport, Marshall, Texas. So, you know, people are kind of, excuse me, that phone should be ringing. People are creative and can go across state lines, you know, to try to fill prescriptions. Evaluate programs to improve prescribing practices. Identify high-risk prescribing. Enhance use of guidelines using the best available science, the newest science. And then look at the MAT, access to MAT treatment that I mentioned earlier. We also want to, health insurers can refer to guidelines. CDC has really good guidelines on prescriptions, how to do that, increase coverage for other types of treatment that reduce pain, physical therapy, and other non-opioid pain relievers as well. So there are things that the health insurers can do. Health providers, and this is the CDC guidelines that you can look at, and it's very informative. Basically, they say look at the lowest level of effective dose for immediate release, and don't do the long-term opioids prescriptions. And then, you know, use the PDMPs to identify patients who use more than one prescriber. Everyone can look at, consider other options for non-opioid pain management. Be aware, you know, of the risks of opioids. Talk to your doctor if he is prescribing opioids. Talk to your pharmacist if you do get prescriptions, and how can you minimize risk for using opioids. And be sure that you store your drugs in a place that is out of reach of children and family and friends and any visitors. Dispose of medications the way that you should. And then there is help from SAMHSA. There's a national helpline, 1-800-HELP, 1-800-622-HELP, that you can have information in their websites that SAMHSA has as well. CDC has. So there's a lot of, you know, information out there that we can access if we have questions about it. And then everything you ever wanted to know about the opioid crisis is at this website. This is hhs.gov/opioids/about the epidemic. Lots of information at this website, and so be sure and access that if you have any more. Okay, keep up the good work of what you're doing now. I'm going to wrap this up. Thank you very much. This is my contact information. If you have, you know, a question, you can email me, juliestevens49@gmail.com. I'm also at preventiontrainingservices.com. as well. So I'm going to stop my sharing my screen and see. I see a chat box. If anybody has questions, you can certainly put them in the chat box. Otherwise, email me, Julie Stevens. I'm going to put it here to everyone, all panelists and attendees. Julie Stevens 49, because I am 49, at gmail.com. Thank you very much. Pamela? You're muted, Pamela. Pam, you're muted.
I'm sorry. Thank you so much. And should we have any Q&A come through, we will definitely reach out to you. And there is a way that we can.
Pamela went away.
Bill, is it 2:30? Ready, set, go? Am I on? Hey, guys. Okay. Obviously, I'm challenged with all this IT stuff. So we're going to talk today about the effects of mood-altering substance use, not just addiction, but use during pregnancy. And I promise to stay on time. We're going to talk about short-term, long-term, generational, and multi-generational effects of some of the substances. Some of these may surprise you, some of them won't. That's just my contact information, Cataldie@yahoo.com if you need me. So our official goals and objectives, talk about the epidemiology of some of this substance use and what ultimate effects there are on the trajectory of fetal development. Talk about some of the diagnostic clues and markers that you may see in these infants. Oftentimes the diagnosis of the adverse effects of substance use during pregnancy are not apparent until they're 10 or 12 years old. And by that time, a lot of damage has been done and earlier intervention could have taken place that would have really helped these children. We'll talk about the etiology. We'll talk about how to recognize short and long-term effects. We'll talk about some intervention techniques and some evidence-based practices. Some caveats, of course, we need to talk about first. I do not have any financial or commercial relationship relevant to the educational content of my presentation and or in the planning of this educational activity. Okay, I'm a visual learner, which means today you're visual learners. I go fast sometimes, I get tangential sometimes, but there's a reason for it. Some of the tangential stuff is because an article I may have read 30 minutes ago is now applicable to what I'm talking about now. But the data I will be giving to you is very pragmatic. Are we okay on our? Is it? Hold on, we're doing technical stuff. So what do I need? Anything on this end? as of this morning at 8 o'clock. We're going to talk about prenatal implications for substance use. We're going to talk about childhood and adolescent trajectory signals, effects that you will see in the adult of a mother who had used mood-altering chemicals during pregnancy. And it's going to be a multi-generational approach, because if mom uses a substance during pregnancy and she has some epigenetic change in the child can transmit that to the next generation. Okay. All right, so just so we're all on the same page in the book here, talk a little bit about this particular diagram, which you're going to see a lot of. Y'all, if you're in obviously into pregnancy and obstetricians, et cetera, nurses, you know what I'm looking at here. But here it is. So ovulation occurs 12 to 14 days after the onset of a menstrual period. And there we see the little egg being protruded out. And as you know, it's into the fallopian tube. Interestingly enough, some people don't realize, I'm talking about patients now, that ovulation actually occurs in the tube, doesn't occur in the uterus. So 1 to 2 days after ovulation, there's fertilization. And then we start to see the migration. You're actually one full cell for about 1 day, 23 hours or so. And then you start changing, you start growing. And then you get differentiation at around day 8, days 4 through day 8. And here we see on day 8, implantation and embryosis. What does that mean? Okay, so you floated, when you were one cell, you started floating and you started changing, and then you got into your mother's uterus and you said, well, I need a home. So you attach to that uterine wall there, and that's called implantation and embryosis. That's going to be the placenta that's going to get you through the next 9 months. A teratogen is simply a factor that can alter normal intrauterine development. And then you see that it can be fetal growth, anatomic structures, which you don't see a whole lot of, physical functioning, and postnatal development, which is what we're going to primarily focus on. So these abnormalities can be due to environmental or chemical exposure. We're going to talk about both. Can certainly be due to maternal medical conditions. You can have medical conditions and psychiatric conditions that are going to adversely impact the fetus because of all the various stress hormones floating around. Infectious agents, certainly apropos for the COVID situation, which we find ourselves now. An infectious agent, if mom gets an infection, for instance, the flu, her possibility of having a child who's adversely affected, like a bipolar disorder or schizophrenia, doubles or triples. Now, the absolute number is low, but it's still increasing the risk to the fetus. And we'll talk about some genetic conditions that mom can transmit on. When we address the fetal effects of maternal substance use, we often kind of divide these things into mood-altering medications or mood-altering drugs and mood-stabilizing medications or mood-stabilizing drugs. Our focus today is not going to be on antidepressants, antipsychotics, stabilizers, mood stabilizers, seizure medications. We're not going to focus on that. But remember, about 10% of pregnant ladies have some type of prescription of one of these during their pregnancy. So we're going to focus on marijuana, tobacco, alcohol, cocaine, amphetamine, hallucinogens, benzos, and opiates. And we're going to do that in about an 8-section process, okay? Confounding variables, there are a bunch. And when I do presentations, I make sure that the literature that I am citing has minimized the confounding variables. Otherwise, I will tell you that there are confounding variables and you need to incorporate that into any decision you make. You can see down there at the very bottom, I'm talking about prescribed and or over-the-counter medications, OTCs. That's really important, especially when you consider if mom's taking acetaminophen, Tylenol during pregnancy. She's increased her child's possibility of having autism or ADHD. If something as simple as Tylenol can do that, what do you think some of these other substances can do? Well, it's pretty significant. But it's not based on just, oh, you took this. A lot of it relates to when you took this. Let me give you an example of that. This is gestational age, time of use as compared to gestational age, okay? So here we see that we've got a fetus, and at 17 days, you see that blue stuff there. Oh, it does work. You see this neural plate forming. That's just a side view of it. That neural plate's going to ultimately be your spine and your brain. And look at this, just 2 days later, look at the advancement. Look at how much is going on here. You're starting to see more tissue, and then you're starting to see that it's starting to take on its own characteristics, anatomical characteristics that are going to be your brain. And oftentimes mom doesn't even know she's pregnant. This is probably one of the worst times in the world to have a binge drinking episode. And you don't even know you're pregnant. And if you look at in Louisiana at the unintended pregnancy rate, or the surprise pregnancy rate, 55 to 62% of all females who get pregnant in the state of Louisiana, it was a surprise. It was not planned. Significant number there. Okay. All right. Let's talk about marijuana. Okay. Marijuana, 40 plus chemicals in a marijuana plant. Tetrahydrocannabinol happens to be, as we all know, we come from here with THC, has about 80 metabolites. So a plant is not a drug. And let's keep that in mind. When somebody says medical marijuana, well, they're usually talking about THC or CBD, but they're not talking about the 400 some odd extra things that are floating around and that may or may not cross that placenta and get into the baby's brain and other organs. And if you look at the THC content, this is comes out of University of Mississippi, by the way. You can see back in 2016, the average content of seized marijuana was 13.12%. That's a lot of marijuana. It's a lot of THC. Okay. And if you look even further at some of the aficionados, and I do run into folks like this frequently in my line of work, some of these, such as Power Plant, have a 28% THC content by weight. 28%. Okay? And it's being grown, of course, usually homegrown. You can get 3 of those seeds for $50. And if you look at the brain's chemical, anandamide, as compared to THC, you'll see that it's very similar. And this is important because in order for a substance to work in my brain, it means I've got receptors in my brain. And if I've got receptors in my brain, I've got a normal chemical in my brain that is there for a reason. It's to occupy that receptor. So I have natural receptors, they're natural activators, and they have a natural function. They have an adaptive function for me. But when I take in something from the outside, exogenous, I disrupt the balance for any substance. Natural receptors are disrupted, my natural activators are disruptive, and the natural function of what they're there for is disrupted. So when I take in a substance that impacts one of my receptors, I'm changing the normalcy of my brain. And if we look at the endocannabinoid system, we'll focus on marijuana for a second. The areas we're going to, you see it's everywhere. It's even called the dirty system sometimes. It's everywhere. Anyway, the endocannabinoid system that we're going to focus on, of course, are impacted by 2 endogenous, internal, naturally occurring, grow inside my brain on their own, cannabinoids. And that's anandamide and, for our purposes, 2-AG. And they're in your brain and spinal cord, hence they're in your reproductive system, extremely germane for this topic today. They're in your GI tract, which is actually going to be important today. And they're also in your immune system. So they can impact positively or negatively your immune system and the baby's immune system. Not just today, 20, 30, 40 years from now as they grow up. And if you look at the parts of the brain that are impacted by THC or cannabinoids, you can see, well, gosh, look, it's the movement, it's the area of higher learning, it's appetite, it's pleasure and reward, it's learning and memory. If you impact these substances with marijuana during pregnancy, these are the parts of the brain that are going to be impacted also. Keep that in mind as we get into this. So how many people smoke marijuana during pregnancy? According to the American College of Obstetricians and Gynecologists, 18% are heavy users during pregnancy. According to the American Academy of Pediatrics, and this is data is 2 years old, if you look at the 18 to 25-year-old females, they report, again, self-report bias, they report 8.5% of them are using during pregnancy. As a person gets older, age 26 to 44, the use decreases, 3.3% report using marijuana during pregnancy. In the United Kingdom, when they did a survey in which they took the meconium of the baby, the first baby poop, 13% of all deliveries were positive for marijuana, for THC. So it's definitely pervasive. And you got to worry about, anytime you do these reports, you've got to worry about self-report liability. People tend to lie, people tend to minimize out of fear, out of embarrassment, or whatever else. So even though we're doing all these wonderful questionnaires, when somebody checks rarely, maybe they should have checked it 1 or 2 up. You never know. You just never know. But we do know that the younger they are, the more likely you use marijuana during pregnancy. We know this. Okay. So let's factor that out as it relates to Louisiana. Here we are, Louisiana again. Now let's take a look. Teen birth rates in Louisiana. Look at that, over 40 per 1,000 females. As a matter of fact, we are very high on the list there. So by definition, if we're having younger people deliver babies, by definition, we're probably going to see more marijuana impact. Teen mothers are at greatest risk for marijuana use, just like teens are at greater risk for marijuana use. Okay. And I want to look a little bit at this because this is epigenetics, don't panic. This is epigenetics. And a gene is just a combination of various, a splice of this DNA. And we got about 20,000 genes in humans. Okay. And those genes are switched on and off. Just because you have a bunch of genes doesn't mean they're activated. Some are activated, some are not activated. Some you don't want activated, some you do want activated. I don't want my schizophrenic gene activated, okay? So here we are, the gene is in the cells and it's being switched on and on to direct the cells what to do, what neurotransmitters to make, who to connect with in other cells, how to think. Okay, that's called epigenetics. And that epigenetics is often primarily impacted by what we call methylation. So if I tell you a part of this gene was methylated, that's going to tell you something about how this gene is telling the cell to do things. It could be telling the cell to line up so you'll be a genius, or it could be telling the cell to line up so that you'll be cognitively impaired, depending on methylation. And we're not going to let Dad off here. Let's take a look at Dad. This is came out of Duke University Medical Center in December of 2018. We know that THC alters a sperm's genetic profile. No doubt about it. That's true. Okay. So it alters gene development. Okay. So you have an abnormal sperm because Dad's smoking. And if Dad smokes once a week, he's going to have abnormalities in his genetic material. Okay. Well, in 2018, they were saying, what does that mean? They had just discovered this. They were concerned about it. They didn't know if it was going to be a permanent thing. I mean, is Dad going to have abnormal sperm the rest of his life? Are those sperm viable? Can they fertilize an egg? And if they do, does that mean all these abnormalities in the sperm are going to be carried over to the baby? Let's go back to that. Now we're 2 years down the road. The latest publication, this is the latest research issued in 2019, and we've actually isolated that there's the gene, doesn't matter, GLGAP2, but the gene is being adversely impacted. And yes, it is epigenetic to the fetus. If Dad's smoking dope once a week, he's changing the way his DNA is being read, and it's going to go into the baby, and the baby's going to have that abnormal DNA. Given. What does that mean? Well, here we are. It's going to cause some difficulties inside the baby's brain, and there's an increased incidence of autism associated with dads who use marijuana. And as of 2020, this morning, today, I read something from Canada that showed that if mom uses marijuana during pregnancy, her increased risk of autism doubles, which in Canada means 4 out of every 1,000 births will have autism or be on the autism spectrum disorder, and can trace back to marijuana use. The other thing that Dad's abnormal gene is doing inside, or abnormally read gene inside the fetus, is that it's causing them to have a propensity to become addicts later in life. Because when we looked at the brain, we saw that marijuana was impacting the reward center, making you feel good. Well, if you're making me feel good, my normal processes are going to be different. And now when the baby comes along at age 14, 15, 16, he or she will be more prone to become an addict. And to the extent that if you look at, this has come out of the Journal of Epigenetics, that there's a striking association between cannabis legalization and autism spectrum disorder. What they're seeing is that areas in which marijuana is legalized for recreational use, they're seeing more autism disorder babies, okay? As a matter of fact, the epigenetic study predicted a 60% increase of autism spectrum disorders in states with legal cannabis by the year 2030. Significant data. Okay? It is the most common form of cannabinoid teratology. Something to be cognizant of. And you know, if you look at the word I try not to use the word teratogen a lot when I'm talking to patients. It's a really harsh word. If you break it down, it means monster, and gen means to produce a monster. Yeah, I know we live in a politically correct world at times, but I don't like this term and I avoid it. I think it's too harsh. Anyway, Cataldie soapbox. So we know that there's an alteration in normal intrauterine development. We know it impacts fetal brain growth. We know anatomical structures are abnormal, albeit these are the tracts in the brain. So if you look at the brain, it looks okay. Physical functioning also may be abnormal, but there is abnormal postnatal development. So if a guy uses marijuana 1 or 2 times per week, he also increases the risk that the fetus will not be viable and that mom will have a miscarriage or a spontaneous abortion. In answer to is the sperm viable, a question that we saw in 2018. Now let's talk about this. This is a human sperm cell forming, a human sperm cell starts its inception over there as one cell, one little half cell, as you see, and it's being transported to the ducts, et cetera, et cetera. The point being, it's ready to fertilize an egg after 3 months. So if you're going to have a planned pregnancy, dad's a user, dad needs to not smoke dope for 3 months in order to give the baby the best chance, okay? How about if mom's smoking it? Well, we know that there are C1 receptors in the uterus. We talked about that. It's actually in the uterine wall. And we know that endocannabinoids, the natural cannabinoids, are released on demand inside the brain and migrate over to the uterus to a specific area. Okay. External cannabinoids, smoking dope, impact uterine receptors when there's no demand. So you're throwing things out of whack here if mom's smoking marijuana. And the things you throw out of whack are implantation and placentation, okay? And ultimately neurological development. Let's look at it. So here we see that there's our picture again. You see the ovary, the fallopian tube, and the embryo's been there obviously for 8 to 9 days at least because it's implanted, okay? And as it implants, in order to strengthen this implantation, our body it synchronizes our normal endocannabinoid levels. Our brain and our endocrine system is saying, okay, we need some endogenous cannabinoid over here to help implant this baby. And the process starts at day 8 or 9, and we're starting to see that there are even different levels and strengths of cannabinoid levels inside the uterus where the fetus is starting to live, okay? As a matter of fact, if mom has, if you take the first trimester and you check her normal endocannabinoid levels and they're high, there's a very high possibility that she's not going to have a viable fetus. Okay? And then you throw marijuana on top of that, and obviously you see where there's an obvious risk for all kinds of bad things to happen. And the literature on this is still believe it or not, is still in its infancy. You would think we'd be a little further along. But we know that exogenous cannabinoids, smoking marijuana, disrupts this process, okay? There's mom over there, she smokes marijuana, and 10 to 30% of the marijuana in her bloodstream actually will be reflected in the fetus's brain and other organs, including the heart, okay? And we also know that when mom smokes marijuana, the carbon monoxide level in the baby increases. That part of that's going to be responsible for your respiratory system developing, et cetera, et cetera. The carbon monoxide level from smoking marijuana is 5 times that of smoking 1 cigarette. That's significant stuff. So bottom line, mom should smoke during pregnancy. Matter of fact, there's a whole movement now called High Moms. Marijuana use during pregnancy harms the baby. And something interesting here is that they did this study, and they got a bunch of people who said they were pregnant, and they went into all these cannabinoid dispensaries in Colorado. 7 of the 10 dispensaries recommended that these women use these products. And they said you need, if you have depression, anxiety, pain, or nausea, what you need is some of these cannabinoid products, which is crazy to me. Some people say that, well, marijuana really helps my nausea and vomiting, and maybe it does. But let's take, there's this thing called cannabinoid hyperemesis syndrome that I think you should be aware of if you're treating these folks. It's episodic abdominal pain, obviously nausea and vomiting, and here's the way you diagnose it. They'll tell you if I take a real hot bath, it stops. Matter of fact, it's pathognomonic, it's almost diagnostic. It's usually self-limited of about 48 hours if you stop smoking dope. It's related to chronic use because marijuana is lipophilic, it likes fatty tissue, likes lipids, and it stores in fatty tissue. It's a paradoxical effect on the GI tract and the central nervous system. So not only is this impacting the gastrointestinal musculature and receptors in your GI tract, it's also impacting the nausea centers inside your brain. As a matter of fact, one of the alkaloids in marijuana actually causes nausea and vomiting, and that's CBG. How about CBD? Okay, we'll talk about CBD. CBD has a low affinity for the cannabinoid receptors, absolutely true. But it has a high affinity for serotonin receptors. And you know, serotonin stimulation and serotonin reuptake, that's all an antidepressant type medication. And antidepressant medication have some benefit in pain. Anyway, purity is a major issue with the CBD stuff. Matter of fact, it's a major issue. THC contamination is quite common. The concentration of the CBD in the product is a major issue. Contamination is an issue with God only knows what. There's no FDA oversight, so you could have toxic metals in there. And if you do a urinary drug screen and the person is taking CBD, the urine drug screen should be negative. If the drug screen is positive, it's going to mean that you have a contaminant or there's no CBD there at all. Now, let's look at this. So, if I'm taking an antidepressant and I take an antidepressant during pregnancy, here are some of the things that happen. I get jittery, my baby's jittery, irritable, has poor feeding, and my baby may have that for about a month. And there's possibly, we don't know this, antidepressants possibly cause increased risk of autism. We do know that there is an increased risk of gestational diabetes, but here's what I'm getting at. The CBD, when you think about CBD, think about SSRI antidepressants. Would you take an SSRI antidepressant during pregnancy? Well, it depends, but if you may see the same discontinuation syndrome if you're taking CBD during pregnancy. So if you're a nurse working on, or if you're got a situation in which you're doing a follow-up on a patient who delivered a child and they're coming back into your office and that child's still jittery and irritable, they may be having some withdrawal from CBD. Something to be aware of. More research is needed, but something to be aware of, okay? CBD, yeah, I think there's some promising effects from it. It may help with chronic pain. It certainly can help with chronic inflammation, can certainly help with insomnia and anxiety, may even be neuroprotective. And I'm not negative about CBD at all. I'm simply saying that buyer beware, number one, and number two, realize it's hitting that serotonin receptor. Does not cause intoxication, does not cause motor impairment, but it interferes with drug metabolism. So if you're taking CBD, there are some medications that it's going to interfere with. It may make them toxic because you get too much because it's not being metabolized, or it may make them ineffective because it inhibits these particular enzymes in your liver. So if I'm taking CBD and it inhibits this enzyme, the 3A4 enzyme, which and 25% of all medications are metabolized by the 3A4, and I'm inhibiting it. By definition, if I take CBD oil, I'm going to have a higher concentration of that 20 of those 25% medications. That could be a antihypertensive medication. Okay? And also, it's also going to inhibit that other enzyme, that CYP2D6. I won't get into it a lot, but you can see, look at all the stuff it causes increased concentrations of. No surprise that if you're taking an SSRI like Zoloft or something, and you use CBD, obviously it's going to increase the concentration. We just got through saying that CBD is also a SSRI stimulant. Okay? So don't use it during pregnancy, the bottom line. CBD has some adverse effects from an immunological perspective if used during pregnancy. It causes increased placental permeability. What does that mean? That means stuff that should not get through gets through. So it decreases the protective capability of the placenta. If you're taking CBD, you're decreasing the protective capability. So that when a toxin, that could be a bacteria, a virus, or a toxin that would normally be repelled by the placenta, because you're doing CBC, it's no longer repelled, and the baby gets a solid dose of the toxin that the baby should not have gotten a solid dose of the toxin if you didn't have CBD on board. Marijuana delivery issues. Yes, marijuana does cause increased stillbirth. So do cigarettes. Low birth weight, if used once a week, yes, so do cigarettes. Preterm birth, yes, so do cigarettes. NICU stay, yes, so do cigarettes. And this comes out of OB and gynecology studies in November 2018. But marijuana without cigarettes does all the same thing. So although there's a confounding variable lots of times, you can tease out that confounding variable and realize that marijuana alone actually does these things. There is no safe use of cannabis in pregnancy. Okay, let's talk about stillbirth just for a second. It increases the risk of long-term depression. If a child is stillborn, you need to monitor these moms for about 3 years, because even if they have another child, that's not going to make this pain go away, and or at increased risk for depression. Even 3 years out, something to be aware of. If you're using marijuana at 20 weeks gestation, you increase your risk of spontaneous preterm birth. And it's very lipophilic. We talked about the blood-brain barrier in the child. Marijuana gets right into that brain. Okay, it readily crosses the blood-brain barrier. Be cognizant of that. Now, let's say mom's been using marijuana and the infant's born. There's no specific marijuana abstinence syndrome for kids, but there's going to be one for mom. If mom's in the hospital and is used to taking marijuana and there's no marijuana available, she will have a withdrawal syndrome, and that withdrawal syndrome lasts about 28 days. And it's really bad the first week, and it's really bad day 3 or 7. Interestingly enough, gabapentin can relieve it. Why is that important? Because she's going to be an unhappy camper. You're going to have a hell of a time. You may have a difficult time dealing with her if she's coming off and detoxing. And let's take a look at that detox withdrawal timeline for marijuana. You can see at day 4, man, craving, restless, nervous, irritable, angry, whoa. And then look over here. They can't sleep, so they're down to the nurse's station saying, I need something for sleep. What's the matter with you people? And of course, if she's breastfeeding, the last thing you want to do is give her a benzo. Again, something to be aware of. So, to summarize for marijuana, the effects on the child developmental trajectory. This is the child from day 1 on out through 72 years old like me. ADHD, conduct disorders, depression, anxiety, and learning problems. Just the areas of the brain you would expect to be impacted are: there's no clear overt teratogenic effect. You're not going to see cleft lip or a bad heart. You may see a tremor and an increased startle reflex for up to 30 days after the baby's born. At 4 years old, these kids have decreased verbal reasoning and memory. They're just not doing well. They're just not learning fast. At 6 years old, they're still having language complications, and they have decreased visual perceptive function. You know, the kid next to them is taking Legos and building something, and they just can't do it. At 9 to 12 years old, they have decreased executive functioning. They're just not as sharp as the other kids, and they have decreased impulse control. At 13 to 16 years old, you'll see that they have decreased problem solving and analytical skill. You'll see decreased attention, so all of a sudden they're diagnosed ADHD. You start to give them medication, and don't forget, if you're giving them short-acting Adderall, By definition, they're already genetically loaded to become addicted. And if you look at the 16 and 18-year-old kids, you'll see abnormal neural activity in their brain capability. And of course, they get addicted more probably. So if I'm smoking marijuana, or should I nurse my baby? Here are the answers. We don't know. There's inadequate data. Neurodevelopment concerns exist. The ACOG and the CDC and the pediatricians all say don't use. Be aware of secondhand use and be aware of third-hand use. The stuff gets in your clothes. Okay. How do you treat marijuana addiction? Well, there's no specific medication for long-term success. Brief motivational interviewing should be done if you found out early on she's pregnant and using. A traditional treatment should be utilized, and follow-up and monitoring are definitely necessary. All right, let's talk about tobacco. What's the epidemiology there? Well, I'll take a sip of water here. Okay. When you look at cigarette use during pregnancy, you'll see dose-dependent effects. And the cutoff mark is, for most studies, it's 10 cigarettes a day. That's kind of, they say, oh, that's moderate smoking, so we'll call that moderate. And if you're doing over 10, we call that's just kind of a benchmark that's been used over the years. Has some validity, but anyway, for our purposes, when you go over 10, equal to or 10 cigarettes a day, you're a heavy smoker. And again, the areas that mom's brain are impacted are going to be the same areas of the brain that get deficit development, of course. And look at all the brain chemicals that are getting impacted by nicotine. Dopamine, pleasure and appetite being a significant thing. Norepinephrine, arousal, being alert. Look at all the learning substances that are being adversely impacted. The cognition of acetylcholine, glutamate, serotonin for mood. And so what's the end result here? What are the cigarettes? If cigarettes are impacting all those substances in your brain, that's why they work. What are they going to do? Well, preterm delivery is pretty common. We talked about that earlier. Low birth weight. This is interesting. If you have a low birth weight child, secondary to cigarette smoking, that child is at increased risk for obesity. And you'll see that around 9 years old, these kids are really obese, which gives them an increased risk for developing diabetes down the road, okay? Also developing hypertension down the road because mom smoked. And up to 1 year, you'll see this autonomic nervous system imbalance. Autonomic nervous system, that's the stuff that makes you calm down or makes you get irritable, makes you sweat, things like that. Autonomic nervous system imbalance is probably going to make you for an irritable child. And that's something you want when you've got somebody who's trying to recover and they've got a child who's irritable at night. And of course, asthma. Moms who smoke run the risk of giving their kids asthma. Usually see it onset at about 2 years old, and it continues on out to 18 years old that we know of. And there's increased risk of sudden infant death if you smoke. Increased risk of ADHD, definitely associated with conduct disorder. If you want to have a kid with a conduct disorder, smoke during pregnancy. Definitely increase in antisocial behavior. Definitely increase in substance use disorder. And even, although incremental, a 2 to 3 times incidence increase of schizophrenia. Although the absolute numbers there are low, there's definitely an associated increase. So greater than 10 cigarettes a day, conduct disorder can be diagnosed, can be expected or need to be looking for it. I'm not gonna say expected. If mom's smoking over 10 cigarettes a day, at age 13, you may see a male who is having a conduct disorder characterized by aggression, etc. For the female at 13 to 17 years old, you may just see a child who's irritable and who is addicted. Okay, so there are gender variances, just like there are gender variances in the brain, there's gender variances in expression. Interestingly enough, if mom smoked during pregnancy, there's actually an increased risk for death in early adulthood. Why would that be? Well, if mom's smoking over 10 cigarettes per day, we just mentioned all the things that are going to happen, the poor impulse control, the conduct disorder, the substance use. So if mom's smoking over 10 cigarettes a day, she risks the risk that her kid's going to die of an injury or an accident as a teenager or young adult. There's no increase in suicide, however. So when you look at offspring in these kids, again, 3 times incidence of schizophrenia. I won't continue to harp on that, but I want to talk about this. Sudden unexplained infant death is associated with mom's cigarette smoking. And you see it starts down there at 1 cigarette. 1 cigarette increases the baby's chance of dying of sudden unexplained death. 1 cigarette a day, okay? And if you look at that, 22% of all sudden infant deaths in the United States are due to maternal smoking. If we stop smoking during pregnancy right now, we would reduce 22% of all SIDS deaths. Isn't that amazing? That's just amazing to me that that doesn't get more press. Anyway, that comes out of the Pediatric Journal, April 2018. So how about, unless she says she wants to stop, what are we going to do? Well, let's give her some nicotine replacement therapy. Well, nicotine replacement therapy is harm reduction. It's nicotine only, so you're not getting all the other stuff, but it's still nicotine and it's still going to have an adverse effect. You're still going to have lower birth weight, you're going to have preterm issues, they're going to end up in NICU more, okay? It may, nicotine replacement therapy, putting the patch on you, may increase your smoking success, but there's no evidence for that. So I really don't think you should be slapping a patch on somebody at this point in time. I just don't, I don't think it. Buprenorphine, Wellbutrin for smoking, no evidence of benefit in pregnant females. Okay. Chantix during, when mom's pregnant, I say stay away from it because it's hitting that serotonin receptor, same thing we talked about earlier with serotonin, and it also increases nausea and vomiting. So probably not a good idea for lots of different reasons. How about breast milk and cigarettes? The child gets 2 to 3 times greater nicotine concentration than that in the mother's serum. Okay, so his mom's just take it. Also, the child is having hypoxia because of the nicotine and decreased sensitivity to hypoxic stress. What does that mean? Well, if I have decreased sensitivity to a low oxygen level, that it increases my risk for sudden infant death syndrome, right? Of course it does. Sleep-wake cycles are often disturbed in these infants for a variety of reasons. Then they have later memory problems. And of course, there's this thing called the long-chain fatty acid. But here's the deal. If I'm smoking cigarettes, it's 2 to 3 times in my breast milk. My baby's getting the nicotine in the brain. They have impaired brain maturation because of this particular substance here. So although tobacco is not a contraindication to breastfeeding, obviously we need to use some harm reduction techniques and ideally stop smoking. Let's talk about alcohol. How does alcohol get to your brain? Well, there's a stomach there. I don't have a pointer to utilize, but there's a stomach and it's generating away. You actually get drunk there. You don't get drunk in your stomach. You get drunk in that first part of the small intestine. That's where all the alcohol really is absorbed. As a matter of fact, you know, not only do you not get so intoxicated by the alcohol in your stomach because it's not being absorbed, there's also an enzyme there that'll break it down. So if your stomach emptying is slowed down like you ate something, you'll actually break down the alcohol. So you don't get a high blood alcohol level. Okay. If you drink a Diet Coke, as 20% of our young ladies do who are drinking out there with hard liquor, if you would, you actually increase your blood alcohol level by about 20% what it should be. That's because that Diet Coke causes gas formation in the stomach and pushes that alcohol into that small intestine. Something to be aware of. Women do not handle alcohol the same way guys do. They have less of that enzyme in their stomach to break down the alcohol. So there's less breakdown, and they have faster gastric emptying, which means they're getting more alcohol into the bloodstream. Therefore, they get intoxicated faster. 1 beer probably equals 1.5 beers. 1 beer to a guy, probably 1.5 beers to a female. People who have gastric bypass surgery, we're talking about mom now, have an increased absorption rate of alcohol. Therefore, they get more rapidly intoxicated with less alcohol, something to be cognizant of. And we're seeing more and more adolescents have this type of surgery, so something to be aware of. The gastric sleeve, same thing. They dump more alcohol into the small intestine faster. Gastric banding, no. If I have a gastric band, not only do I not increase my alcohol consumption, I generally decrease my alcohol consumption. But let's talk about why do women, or young ladies particularly, get more impaired with less alcohol? Well, it's more concentrated in females. If I have less body water, by definition, I don't dilute it as much, okay? I've got less enzyme, which we just talked about. 100-pound female takes one drink on an empty stomach. Her blood alcohol level goes to 0.03. Okay, 3 drinks, she's legally drunk. And it's one drink increases her risk of being killed in a motor vehicle accident. And if she takes 9 to 10 standard drinks in an hour, she dies. And in Louisiana is #1 in the nation for teen drinking. If you look at our 9th and 10th graders, 34% of them consume alcohol. And that is a tremendous amount compared to lots of other states in the nation. Okay? It's just significant. And how about those blackouts? What are those? Amnesic episodes. 55% of undergraduates who had ever consumed alcohol have had blackouts. If you're at LSU and you're an undergrad, you drink, you're gonna, half of you are gonna have a blackout. First year medical students have blackouts. And risky behavior follows. So who thinks it's scary? About 60% of the females say, man, that blackout was scary. I don't know what happened. That scares me. Only about 25% of the males say it was a big deal. Oh, I had a blackout, so what? Blackouts are not diagnostic of alcohol use disorder or alcoholism. They're simply related to how fast you ingested the alcohol. So it's how fast you ingest the alcohol that causes it. Females are more susceptible. It does cause amnesia. You really don't remember. You may remember some things, but most things you don't have any memory of. And that's really significant because you can get pregnant during a blackout and you don't even know you're pregnant. Okay? And if mom's drinking during pregnancy, it's dose and time dependent. We saw earlier day 19 to 21, man, not the time to be binge drinking, right? And if you look at fetal alcohol toxicity, if mom's drinking, there's an equal concentration of the blood in the baby as it is in mom. And in the amniotic fluid, what's that mean? The baby's floating in a vat of alcohol. So if the baby's doing any swallowing or to get meconium, the baby's also getting alcohol there. This is a horrific type situation. And that little liver is not going to manufacture, not going to do much. And that's significant because acetaldehyde, which is toxic, the first byproduct of alcohol, is not going to be metabolized as fast. And you say, well, the alcohol concentration of mom is equal to that of a baby. That's absolutely true. If mom takes a drink, you got to ask her, would you give that same drink to your baby on day 1? And if you look at the data, looks like about 1 out of every 10, some people say 1 out of every 9 women drink to the point during pregnancy that's significant. 3% are binge drinkers. That's significant. Why is that so significant? Because 1 out of every 100 children in the USA are born with fetal alcohol spectrum disorder. 1 out of every 100 in the United States of America are born with fetal alcohol spectrum disorder. And in some areas, it's up to 5%. And if you look at those syndromes, there they are. I'm not going to spend a whole lot of time on them, but suffice to say that a lot of these things are very significant and cause significant impairment. And if you look at the clinical presentation, you can see that the midface just didn't get developed, didn't develop the midface. That nasal ridge is real low. The eyes, the palpebral fissures, the distance between the eyes is about 30% of what it should be. And you don't have that little bump that little groove on your upper lip. And oftentimes your upper lip's real thin. When you see this type of presentation, these kids are going to have a hellacious time the rest of their life. You need to be able to diagnose this right off the bat because there are some therapeutic interventions and training and learning that can really help this kid. And here's some of these are fetal alcohol kids, all of them. These are all fetal alcohol kids. You see the palpebral fissures. You see the nose is just mid-face and developed. You see the thin upper lip, and you see that groove is not what it should be. Let's take a look at Liz. She's 21 years old. She's got cognitive problems. She just didn't do very good in school. She just didn't learn very well and had to get into some special ed. She's having a lot of difficulty with social integration. She doesn't recognize cues. She doesn't socialize well. She's very vulnerable to manipulation by others. She has very decreased insight. She's kind of concrete. And concreteness is one of the signs that you will see in adults who have this syndrome. Her executive functions are low, and if she drinks, she's probably going to be instant alcoholic. With early intervention, she can be functional in society. Let's talk about marital bliss or bias in alcohol divorce rates. If the husband drinks, oftentimes the female will stay. But if the wife drinks, oftentimes the male will leave. Something to be cognizant of, because when he does leave, he leaves and doesn't take the baby usually, especially a fetal alcohol baby. So how do you treat alcohol use disorder when mom's pregnant? You don't. All these substances that we would use normally to treat alcohol use disorders are contraindicated during pregnancy. So you got to go back to regular treatment and motivation, et cetera. Amphetamines and methamphetamines. I'm going to talk about amphetamine-like substances. Both amphetamine and methamphetamine, these are the two most commonly seen, we're seeing more, impact the neurotransmitters, serotonin, which is kind of your antidepressant, norepinephrine, which is antidepressant and gives you alertness, and dopamine, which makes you feel good. So the degree of impact on amphetamines is dose-related, it's potency-related, it's duration. When did you take it? During what part of your pregnancy did you take it, okay? How pure was it? What were the contaminants? Did it have ecstasy in it? That's going to change the ball game. What metabolites are there in these particular substances? And how did you take it? Because if I shoot it, I get a tremendous surge of a drug inside my system, and that's going to be more detrimental than if I took it by mouth and I didn't have that tremendous surge. Because when I got that surge in my system, the baby got that surge in his or her system. Okay? If you look at the difference between amphetamine and methamphetamine, methamphetamine causes 500% the dopamine release inside the nervous system. 5 times, that's a tremendous boost. Okay, boom, wow, I feel great. And both amphetamine and methamphetamine cause fetal accumulation. If mom is using, even if it's every other day or every third day, it's building up inside the baby because the baby can't metabolize it that fast. Mom's out there saying, oh, I need some more meth, and the baby's still loaded up because of the increased fetal half-life. Because that little liver won't do it. Can't get rid of it as fast enough. Here's a little tangent. I just want to show you a pill making machine. And I want to show you those counterfeit pills. You see the machine on your left. You see all the pills on your right there. And then those things look pharmaceutical grade, right? This is made in somebody's garage, of course. And look at them. If we take these little bitty imprinting devices here and put it in the machine, we can make any kind of pill we want. So I'll dump all this powder in there. It doesn't matter what's in it. Maybe some methamphetamine in it, maybe some fentanyl in it. And I press it out. I can make it press out as an oxy, or I can make it press out as a Xanax, or I can make it press out as an amphetamine. Speaking of amphetamines, we talked about that massive release, but for every action, there's certainly a reaction. And if you look at methamphetamine and amphetamine impacts on the fetus, it's very significant. Serotonin and norepinephrine have lots of things going for them, right? We say, oh yeah, mood. But don't forget that these serotonin also impacts platelets and clotting. So let's talk about that for a second. Since it's impacting the circulatory bed, you can see elevated with methamphetamine and amphetamines, preeclampsia, eclampsia, and hypertension are much more common and can be precipitated. And abruption of the placenta tears away from the uterine wall because, again, of the methamphetamine vasoconstriction and the clotting difficulties. Amniotic fluid homeostasis is disrupted. You've got methamphetamine, amphetamines, and all kinds of metabolites floating around in there. Okay. Preterm delivery is not uncommon because it's going to stimulate that ovarian muscle wall. Growth restriction, mom's not eating anyway. Low birth weight goes hand in hand with methamphetamine use, as does neonatal death. There is indefinitely increased risk of death after birth with these methamphetamines. And again, the serotonin impact on platelets promotes the hemorrhaging. So definitely something, if somebody comes in there and you've got a positive drug screen, or they tell you they're using meth, all these things, and they're pregnant, all these things should go through your mind. So is there stimulant, a neonatal abstinence syndrome? Well, we're back to the chicken and egg thing. Is it the stimulant effect? Because we just said the baby accumulates this stuff. Or is it stimulant withdrawal because the baby's here and now is not taking methamphetamine? The research on this is ridiculously slim. We do see a methamphetamine-related syndrome that can occur 24 to 48 hours after birth and last 7 to 10 days. You'll see feeding problems. You may see low arousal, or you may see hyperactivity. You will see sleep disturbances. You may see muscle tone decrease and have low quality of movement. And all thing you do is kind of do supportive treatment. Again, be cognizant of it. Methamphetamine overdoses are rising in the United States. We've been in the midst of a meth pandemic. Whoa, one at a time. We've been in the midst of a meth pandemic for years. Look at that, 20 years. But it doesn't get much press for some reason. How about Louisiana? Well, the DEA, Project Crystal Shield, has identified 8 major methamphetamine transport hubs, and New Orleans is one of them. So there's plenty of methamphetamine in Louisiana. And if you look at drug overdose deaths by regions, drug ODs, fatal deaths, look at Louisiana. Look at this. Methamphetamine is the top drug involved in overdose deaths in Louisiana. That's significant. It's here. And with that methamphetamine comes psychosis, delusions, anger, detox, suicides, where you can see all this going on. There's going to be increased intimate partner violence, skin dysfunction, elevated temperature, your muscles break down and cause your kidneys to break down, seizures, strokes. So how many pregnant patients use methamphetamine? Again, this is self-reported data. 1 to 5% supposedly, depending on who you read. So what are some of the diagnostic cues? Everybody seems to think that if you're on methamphetamine, you look like death eating a cracker. That ain't true. Is this not your typical methamphetamine? I have several patients in my practice who are morbidly obese, who use methamphetamine on a regular basis. I have patients in my practice who are skeletal, who use methamphetamine on a regular basis. Don't let that bias get in your way, okay? Beware, do not stereotype these folks. Don't stereotype any person who's using mood-altering substances. It'll get you in trouble, okay? One thing you will see with methamphetamine quite commonly is that body-focused repetitive behavior, skin picking. And something else you need to be cognizant of is that some men use methamphetamine to enhance their sexual performance. So this is a perfect match. You got a guy who has sexual dysfunction and he's also a meth addict. That's who you want to be your dad's father, your kid's dad. And here's the other thing. These sperm cells are loaded with methamphetamine, and there's a lot of concern about the epigenetic legacy that dad's going to leave if he's using methamphetamine and impregnates mom. Now, a lot of methamphetamine folks combine, we used to call speedball heroin and cocaine. We still see some of that, but we're seeing more and more heroin and methamphetamine. Of course, the heroin is mostly fentanyl, but we're seeing more and more of this. We're seeing more and more of the speedballing. So it's going to be a double whammy on that sperm cell and on that fetus. Again, something to be cognizant of. So how many people are using it? Well, if you're an opioid user, 32% of you are using it. And why are you using it? Well, it's to balance out that heroin. It actually gets you higher. So if I don't have a lot of heroin or my heroin's weak, I can use a little meth on top of it. If I start detoxing, I can use some meth. It really does help, believe it or not. Not in a good way. So it becomes because it gives you the energy. And one of the withdrawal problems people complain of a lot of opiates is I don't have any energy. When you do a drug screen on these folks, you're going to see methamphetamine, a dipstick, methamphetamine, amphetamine, and MDMA. Now, that may be some cross-reactivity there, but there may be contamination of MDA in the methamphetamine that the person was utilizing. And methamphetamines, addicts die more in the hospital. This is something to be aware of. All addicts die more in the hospital because there you are sitting there with that nice IV line. You've got a drug tolerance. They're not giving you what you want. You make a phone call and somebody will bring you anything you want. Again, monitor these folks closely and keep the Narcan handy. One of the things that methamphetamine does is decrease your ability to recognize facial emotion. So you misread facial expression, and if I misread your facial expression, I'm going to give you an inappropriate response, right? You're going to think I'm crazy, and I'm going to think you're crazy. And when you misread facial expressions and give those inappropriate responses, it usually escalates. Lots of times, not uncommonly, not say lots of times, a methamphetamine addict may interpret your concern, facial expression of concern, as anger or disgust. And then, of course, that's going to lead to other issues. And if you look, these are just areas of the brain that actually are impaired that cause you to have inability to detect facial cues. It actually is toxic to those parts of your brain. I'm not going to dig into that too much, but if you can't interpret facial cues, it's going to impact your parenting capability. Meth addicts may or may not be able to appropriately or accurately interpret their children's cues. And if you look at them in group, they can't interpret facial expressions, so oftentimes they look apathetic. They're just not there. But here's the one thing they do. They have increase or augmentation of processing negative input and of processing pain. And that's going to last. By the way, methamphetamine withdrawal lasts at least a month. So putting these people in a 28-day treatment center and zooming them back out of there, you may or may not have touched them. Now let's look at this. This is meth and neurogenesis. What is that? Neurogenesis is the making of new brain cells. Hopefully we're all making new brain cells right now because of all the dynamic training you're getting right here. And I hope that I continue to make brain cells in my hippocampus until I die. It's one of the things that keeps me from getting dementia, okay? Now let's look at this a little bit. So here's Lou the rat up here. And you see you've got these nerve cells up there that are maturing over there to mature nerve cells, okay? This is a maturing process of nerve cells. Now, here I am, I'm loaded up on methamphetamine. Okay. And if you look at these nerve cells, you'll see in my hippocampus, they're not being produced, okay? It's not happening. I'm not maturing. When I use methamphetamine, I no longer have the ability to make new brain cells in my hippocampus. I ain't learning anything, okay? Nothing new is happening, okay? Now, I'm off the methamphetamine. I'm trying to get straight again. I'm saying, oh, I'm gonna do whatever I need to do. I'm abstaining. I'm not gonna self-administrate that stuff anymore. And all of a sudden, if somebody was looking at me, they would see, look, Lou's brain cells are growing back. Yeah, they're growing back, but they're different. They're not growing back normally. As a matter of fact, they're growing back abnormally. I now have a growth of brain cells are abnormal. Okay? Their circuits are abnormal. And every time I use, I get more and more abnormal circuits. And these abnormal circuits become permanent, and that's called hard wiring. What parts of my brain are getting hardwired? We all have a ventral and dorsal striatum. These are the reward centers of our brain. If you look at the ventral striatum, that's the part of the brain that gets all excited when you hit a home run, or your kid does something wonderful, or you use heroin. So, boom. When I use a substance repetitively, my ventral striatum starts to connect with my dorsal striatum, and it starts to hardwire in. My dorsal striatum is the habit hub of my brain. We could spend a day on this, but take my word for it. Ventral striatum gets me high initially. Over a period of time, my dorsal striatum becomes impacted, and using becomes a habit. In other words, using becomes normal. And my prefrontal cortex, that executive part of my brain, responsible for reasoning and being able to delay gratification, becomes impaired. And if you look at a meth brain, here's a healthy brain over here to your left, I hope. Here's a meth user, 1 month into it, that light's just not very high. That light's kind of dark. 1 month into abstinence, this person's still not processing data well. And if you look down the road there at 14 months, yeah, that brain's better, but it's not back to normal. Here's the bad news. It may never come back to normal. 3-year follow-up studies have shown that it improves, but it didn't get back to base level. So if mom's using amphetamines and methamphetamine, should she nurse? The answer is yes. But let's say just amphetamine. Let's talk about that just for a second. I'm going to give you a quick case study. This is out of the Journal of Perinatology. So mom's taking Adderall 20 milligrams per day. I think in this particular person it was 5 milligrams 4 times a day for narcolepsy. When you look at the amphetamine level in her breast milk, it was 3 to 7 times higher on a regular basis than in her maternal plasma. Okay, 3 to 7 times as high. So now we're looking at the level that you would get from 60 milligrams to 140 milligrams of Adderall a day. Okay. The urine from the infant is positive for amphetamine. The infant plasma level, however, is much lower than the maternal level. So we can negate the fact that although there was a higher concentration in breast milk, that higher concentration did not play out as a super high concentration in the baby. So the infant plasma level was much lower than mom's level, okay? As a matter of fact, it was only 5 to 15% of mom's level. Something to be cognizant of, obviously, amphetamine use in a controlled study like this is certainly not contraindicated. But let's look at, that's PME means prenatal methamphetamine exposure. So prenatal methamphetamine exposure, mom used meth during pregnancy, and now we're looking at her 3- and 5-year-old kids. They have delayed motor development. They're just not as coordinated as other kids. They have decreased attention. They're just can't stay on track. Okay. At 5 years old, they're starting to see a diagnosis of elevated diagnosed rates of elevated ADHD. This doesn't mean everybody's getting it. I'm just telling you, this is what to look for. They're starting to see emotional reactivity. Now, this is significant because emotional reactivity is just that. Either they're very anxious or they're very depressed. I'm not bipolar, it's just increased emotional reactivity, more sensitive, if you would, okay? And if you look at them in school age, these are prenatal methamphetamine exposed kids. They have cognitive dysfunction, behavior dysfunction, decreased self-control, and decreased executive functioning and emotional reactivity. And if you look, don't forget that ADHD, I'm not going to go into it heavily, is not the same in females as it is in males. There it is. And males are a little bit different. Okay. Males have more neurobehavioral disinhibition, and they act out more. And if you look at these kids, let's take a look at these kids. Okay, here's this side of the Journal of Pediatrics. Let's take a look at these kids. Let's take a look at their brains compared to their friends in the same grade, let's say, and let's see what happens. And when we look at the brain volume of these kids whose mom used methamphetamine, oh my gosh, they're not as big. They have decreased brain function and decreased brain size, decreased brain wiring in these areas. And these areas simply mean they have decreased attention, they have memory problems, and they have learning problems. Okay? They also are going to have altered white matter maturation in their prefrontal cortex. What's that mean? That means that they're not insulating the nerves like normal people would, which means there can be overlay or short circuiting. You know that if you have 2 wires and you skin one down, they'll short out to the other wire. Anyway, they've got decreased white matter in their prefrontal and frontal and parietal cortex. This is executive functioning. This is impulse control. And here's mom. We'll take some rats here. And we got a mom meth rat, and we got a mom who didn't use meth. Okay, and then we're going to inject the adult rat, okay, with methamphetamine. And when we inject the adult rat with methamphetamine, and his mom was a methamphetamine dependent rat because we did that to her, he has a super cool response. Oh, wow, I feel great. How do you know that? Well, because of his activity levels and they're monitoring his brain. Let's take mom who didn't use methamphetamine. This comes out of environmental epigenetics. And let's hit him with some methamphetamine. And he gets a little bump, but no big deal. he's not going to go crazy in the maze looking for it. But rat number one up there is, so if mom is using methamphetamine, it increases the kid's response or sensitization to methamphetamine. So how we treat methamphetamine disorder? Not well. We got a lot of target areas of various neurotransmitters, but the bottom line is we've tried lots of stuff. We've tried minoxidil or Provigil. We've tried Wellbutrin. We've tried naloxone, which is an opiate blocker. The idea behind Wellbutrin is that it stimulates dopamine and norepinephrine and serotonin, but it doesn't do it well enough to do any good as far as stopping methamphetamine use, okay? I've tried this. I've had no results with it, and very, very poor results. Let's give them some methamphetamine. We'll just give them methamphetamine and see if that does it. It doesn't. Let's give them Ritalin, see if that does it. It doesn't. Let's give them topiramate, which is an anti-seizure medication. Actually, topiramate actually works some, but the side effects are, it makes you feel like you've got a lead helmet on, and lots of people will not continue to take them. The compliance rate's low. So, is there going to be a meth medication-assisted treatment, or we could like Suboxone for opiates? Well, they've tried everything. You can see all the things that people have tried without results. At this point in time, we have failed to find anything that's going to do anything. So what are we going to do then? Well, when all else fails, do treatment. Brain rehabilitation, behavioral rehabilitation. This is extremely important. Don't forget, it's going to take that brain years to heal. So there has to be some external accountability for these folks. It's hard to keep these folks motivated, but they've got to be given purpose. Any person in recovery needs purpose. Any person needs purpose. And it's important to rectify their identity. They've got to identify their role obligations, do values clarification, do mood rehabilitation, because they're hypersensitive. Coping skill rehabilitation, oftentimes they have cast themselves in the victim role. Contingency treatment works. Short reward, since these people who are using methamphetamine have brain damage to the parts of the brain that cause you to value delaying your gratification, okay? If we can give them a reward every time they do something good, obviously we start to reinforce adaptive healthy behavior. What is that? Reward doesn't have to be anything. It can be a token, and you get 10 tokens, you get a Coke or something, or a soft drink. It's just like, you remember, I guess they don't do it anymore, but when I was a kid, if you got a gold star or a red star, it was a big deal. And it's important to do that. How about PEA? PEA is a CNS stimulant. It's in your brain. It's made in your brain. It has amphetamine-like effects. It increases your dopamine and your norepinephrine and your serotonin, all true. It's an over-the-counter supplement. It does give you some energy, and it probably can help you lose some weight. And if you look at the family of PEAs, when you substitute certain parts or certain molecules on a PEA, you get what we call substituted PEAs. One of them is amphetamine. So again, this may have some value. I'm not anti or pro at this point in time. I don't think it can hurt anything. Okay. We're seeing rising cocaine death rates in the United States. I used to think, oh, thank gosh, the crack epidemic is gone. It's back. Cocaine's back, and you see it rising. The prenatal effects are similar to the amphetamines. I won't renew all that, but I want to talk about this. We talked about the fact that there's a gender difference in brains. The female cocaine addict has a decreased amygdala response during craving. What does that mean? The amygdala is a part of your brain responsible for, as you know, fight, flight, okay, or freeze. What if it doesn't go off? What if it doesn't alert you that it's dangerous? What if it's blunting? That means you'll be more prone to take the risk of taking the drug. I can tell you all how dangerous it is, and then you get exposed to the drug and your amygdala doesn't fire off, and you say, man, not that big a deal. Unfortunately, females tend to have more euphoria with cocaine, and they are more prone to use cocaine to self-medicate depression, albeit the depression may be indeed due to the cocaine. It's a vicious, horrific cycle. Let's look at mom's maternal brain changes if you use cocaine. You can see the areas of the brain that are adversely impacted. You say, oh my gosh, those look like the parts of the brain that you talked about with methamphetamine. Yes, that's true. And so if mom's paternal brain changes are this, she's going to have neurocircuitry of parenting disruption. What does that mean? Regular use of cocaine is going to cause mom not to be able to respond to infant cues as well as she should. Her executive function is going to be decreased. Her reward center is going to be abnormal, which means she's going to be more irritable. Her stress tolerance is down. Her coping skills are decreased. Her learning skills are decreased. She's not encoding data. We talked about that. It's the same thing with methamphetamine. Her response to cues like crying, et cetera, are impaired. So all these, and then on top of that, let's dump this. What about the psychological factors? What if she was abused as a child? What if she has PTSD? What if her attachment style is not that of a healthy person? All these things need to be factored in when you're dealing with somebody who has been dependent on cocaine and is now parenting. We need to help these women learn these things and have some accountability. So the long-term effects are prenatal cocaine exposure, as you would expect, pretty much the same as with methamphetamine, so I won't beat you to death with that. But here's something that's different. Maternal cocaine use and the cardiac effects of the child. There are actually changes that occur if mom's using at a cellular level. And look at that heart over there. We talked about times of development that are important. Man, on day 15, that little heart's starting to develop, okay? And day 21, yeah, it's starting to look like a little heart. And my gosh, we know it definitely it's a heart by day 50. So there are changes at a cellular and genetic level that's going to program for myocardial infarction or heart attack in adulthood. Yeah, you're going to see young adults or middle-aged adults having more risk of having heart attacks because mom used cocaine during certain times of her pregnancy. So if mom's a cocaine user, she certainly needs to be able to tell her kids, hey, look, you need to see a cardiologist on a regular basis, okay? Here's something else about cocaine. If you drink alcohol and use cocaine, your liver acts like a manufacturing machine. And it puts out a thing called coca-ethylene. So if I drink alcohol and I take cocaine, I get coca-ethylene. Coca-ethylene's toxic. It's much more toxic than either separate chemical. Coca-ethylene, it stays around for 3 to 5 times that of cocaine. Therefore, it becomes attractive. If I can prolong my cocaine high, why wouldn't I? Well, it does have an 18 to 25 times risk of sudden infant death. It'll stop your heart. Also, it's toxic to your liver. So your liver is toxic, but it'll keep manufacturing the coca-ethylene. You're more prone to have seizures. It alters your immune system, causes cardiac disease. And in the fetus, it causes abnormal brain development. Very toxic. So if mom is using cocaine, you need to find out if she's using alcohol concurrently to factor in coca-ethylene down the road. Benzos, all forms, shapes, and sizes. The acute effects, if you're going to see the impact of benzos at birth, you're going to see low muscle tone, difficulty regulating temperature. They may stop breathing, and you may see seizures, a tremor, and irritability if mom's been using. Or if mom just got an injection of a benzodiazepine just before delivery, you may see this too. So if I want to make an addictive drug, what would I do? Well, I'd like it to alter your mood predictively, okay? I'd like it to be readily available, yeah, okay. I'd like it to have rapid onset, that sounds good. The length of the effect, actually the shorter the length, the better off because you'll have to come back and get more. And I'd like to have it have withdrawal effects because if you withdraw, you're surely going to come back and get more. And what we just described, of course, are short-acting benzodiazepines. Not all benzodiazepines are created equally, obviously. Valium, which is a long-acting, been around for what, 60 years plus, it's very lipophilic. It likes fatty tissue. And anytime you see something that likes fatty tissue or is lipophilic, you know it's going to zip right into that baby's brain. Xanax has a short half-life and is very potent. Short half-life means it's not going to be around for over, we'll say 8 to 12 hours. But one of the things it's going to do is give me a bump. It's going to peak and give me a bump. Oh, wow, feel good. Not good. Not good for the baby. We like to avoid peaks of any type of medication in a developing fetus. Clonidine, I think it's been around since 1980. It's very potent. It readily crosses the blood-brain barrier. And these are the three most people request. Here are the ones they don't usually request. These are lower reinforced and aren't as addictive. I have yet to have a person come in my office, unless they're withdrawing from alcohol and know me, and then say, I need some Cirax. They don't do it. Nobody comes in and says, how about some Transine, doc? When's the last time somebody came in and asked me for Librium? I can't remember. Why? Because these drugs are not as reinforcing. They don't get the bump. They don't get the euphoria, okay? They're slow in onset. People want immediate relief. Unfortunately, immediate relief creates the expectation that you're going to have immediate relief, and it's very addictive. And you won't see these on the street. All right, here we are again. There's impregnation. Looks good. Impregnation, implantation, right? All right. And we'll talk about this with benzodiazepines. Everybody got it? Good. All right, now let's introduce Klonopin. Or Xanax, it doesn't matter, or Valium. So mom's taking that. What that does is going to decrease the contractility of the fallopian tube. So there's impregnation, boom. And there is ectopic pregnancy and very possibly a fatal hemorrhage in mom. Women who use benzodiazepines up to 90 days before pregnancy have an increased risk of an ectopic pregnancy. The general rest of the public for ectopic pregnancy is 1 to 2%. If you've been using benzos, it's higher. 6 to 13% of the pregnancy-related deaths are due to ectopic pregnancy. The number one cause of death in the first trimester of pregnancy is hemorrhagic ectopic pregnancy. Benzodiazepines increase the mom's risk 50% higher than ectopic pregnancy in the general population. So now we're at 4% risk. That's pretty damn high. That's pretty high, excuse me. Because benzodiazepines is decreasing the muscle contractions in the tube, so the fetus, the developing egg, the developing embryo gets stuck. Okay. So I'm sorry for that aside. Number one leading cause of death for pregnancy, associated pregnancy in Louisiana. This comes out of the American Journal of Pediatrics, 20 to 2017. The risk of homicidal death is 2 times greater during pregnancy. Homicidal death, 2 times greater during pregnancy and postpartum period when compared to females who were not pregnant in Louisiana. Congratulations. All right, so what about pregnancy? Is it going to cause birth defects? It's a mixed bag. Nobody really knows. Here's one thing we do know. It can cause internalizing behavior, which means kids internalize negative feelings. It can cause preterm delivery, and there's a possibility that it causes congenital defects. We know that Valium indefinitely does cause those defects. Oops. All righty. Something happened there that I don't know what happened. We obviously didn't load the whole thing down for some reason. Try again. Okay, we're having trouble. Can you hear me though? Well, we're having this trouble. I can't answer any questions. But we missed a whole section down here somewhere. I'm sorry? Let's see if we can get up here and get it back. I have no idea what happened there. I apologize. Everybody probably needed a break anyway. All righty. back. Talked about that. Talked about that. Okay. Lots of controversies with benzodiazepines. Is there a risk of cleft palate? Yes and no. It's a very low risk. If you use benzodiazepines in the first 2 to 8 weeks, there's probably an increased risk of cleft palate. It's not an absolute risk, it's a low risk. Absolute numbers are low. But everybody would agree, at least I certainly would, that you should avoid first trimester use of benzodiazepines. Try to avoid high peak levels. What does that mean? Don't use that stuff that gives you a bump. If you're going to take them, take one like Transine or chloridazine epoxide. Lorazepam or Ativan, most people will tell you it's contraindicated in pregnancy. It's been associated with anal atresia, which simply means you don't have an anus. And ultimately, if you use just before delivery, you got to worry about floppy baby. If you're going to breastfeed, definitely monitor for sedation and definitely monitor for sleep apnea or SIDS. So what are the long-term effects? Well, benzodiazepines affect a GABA receptor in your brain. Your GABA receptors during pregnancy are constantly increasing in the infant, constantly, until birth. So if I'm using benzodiazepines with any regularity, I'm going to have a decreased number of GABA receptors in my baby, which means as early as the 8th week of gestation, and we've already said don't use between week 2 and 8 because of the risk of cleft palate. If I'm starting to use at 8, I'm starting to see that my GABA is starting to develop. And you're going to see the front part of the executive part of the baby's brain between 12 and 26 weeks is developing to the extent that it's requiring these GABA receptors to be activated. Not a good time to be taking benzos. And we know that prenatal diazepam is associated with chronic anxiety in animals. So what does that mean? Well, if you use benzodiazepines in pregnancy, here are some of the risks. You're decreasing the GABA receptors in your baby's brain. They're probably not coming back. The effects on the child, of course, you can have withdrawal. But we're worried about anxiety disorders later in life. And we know, though, that there is a dose risk response, okay? And that in the first if you take benzos during the first trimester, you run the risk of miscarriage. About twice the normal. Gabapentin, stay away from it during pregnancy. It can cause muscular abnormalities and heart defects. Always keep in mind that we all have a homeostasis. We're all where we should be or the best we can right now. And if I take in a substance, which we talked about earlier, it causes allostasis, which is an adaptive steady state to compensate for the stressor. What's a stressor? Could be an amphetamine, could be methamphetamine, could be an opiate. Don't forget that there is an action cascade. So one system is affected, other systems are going to be affected. For instance, methamphetamine. Methamphetamine causes an increase in prolactin release, okay? And then it causes that, so there you have the GU tract being inflated. It causes problems with immune function and fertility. So even though it's being taken for central nervous system effects, it's having an effect everywhere. Homeostasis, stressor, allostasis, stressor goes away. The idea is, do you ever return to normal? And with some of these chemicals, you probably don't. Let's talk about opioids. We all know there's an opioid crisis. I won't get into it. We all know why. Big forum. We all know Louisiana has been one of the top prescribing entities in the nation. And we all know that there's a conspiracy of silence. There's a reluctance to self-report. Less than 30% of women, if you ask them if they're using, are going to say yeah, and then they're probably going to minimize. So these self-reports are kind of useless. Not useless, need to be taken with a grain of salt. Why do they lie to you? Well, they fear consequences. They don't want DCFS knocking on their door. They may have some legal issues. They may have some custody issues. They may have safety issues. They don't want their old man beating the hell out of them tonight. And they're often fearful of drug screening. They don't want it, and they've learned ways to manipulate and not do it. Motivational interviewing is the best way to approach this. You've got to develop some trust, because as far as she's concerned, honesty is stupid. And she's learned that from us, guys, because of our provider bias. If you interview nurses who treat, well, this is 2 years old, who treat these patients, they'll say 76% were angry about mom. Now, if you're angry at a patient, it's going to come through, all right? Because they have a lack of training. They see it as a willpower issue. They don't realize that they can have support services to help these people. And if you increase the education of your physicians and nurses, yes, physicians and nurses, you have a better foundation of understanding. It can decrease your frustration. It empowers you to offer something to these patients, okay? So what's the consequence of these biases? Well, number one, there's a negative perception of the birthing process. And these women can develop PTSD because of the way you treated them in hospital. Two things are going to happen there. They are never going to trust the system again when they get pregnant next time. It ain't going to happen. Okay, you've trained them not to. Okay, and they've got other additional risk factors for PTSD. And I submit that this is a susceptible population. A lot of these ladies have a history of previous sexual trauma. A lot of them have had perinatal depression. They're pregnant, they're using drugs, they're depressed about that. They have a lot of anxiety about that. And a lot of then you get this postpartum depression. Let me tell you what, you cause PTSD in a woman or be part of causing that process, you're going to decrease that bonding to that infant. And you just set that woman up to have not only a bad experience in hospital, but to have a bad postnatal experience. And the child's going to suffer too. If you don't treat these babies, they're going to have premature delivery. They're going to have fetal stress. You're going to see miscarriages. We talked about all this. I'm not going to go over it anymore. But here's mom using heroin. Now you can see that what's happened is that her blood levels are fluctuating drastically. And when they fluctuate, the baby's levels are fluctuating. She gets up in the morning, she's sick. She gets out and scores some dope. She just takes enough to get functional. She starts to detox, and baby starts to detox during the day. She overamps, she nods out, which means the baby is nodding out. Okay, so what are we going to do? Well, the focus now is on harm reduction. And I just want to tell you, opioid agonist therapy, buprenorphine, methadone, is harm reduction. Let me reemphasize that. It's harm reduction. Okay, we're still doing harm. Every time I write a buprenorphine prescription for a pregnant woman, I'm doing harm. Now, I may not want to admit that, or this is not a magic bullet. A methadone and buprenorphine, both addictive, both harmful. You have to do a cost-benefit analysis every time you write this stuff because you're actually causing a controlled dependency. You're trying to minimize the damage from her lifestyle. You're trying to be able to anticipate the outcome more accurately, but you know it's going to be adverse. And you got to realize that this opiate that I'm prescribing is going to have impacts from delivery on up to adulthood. And if you look at the mother studies, the maternal opioid treatment human experiment studies, there's no doubt that buprenorphine has an advantage over methadone. I don't think methadone should be used in moms. You see right there that hospital stay is shorter, the duration of neonatal abstinence is shorter, the total dose of morphine required is shorter. I don't think it's a good drug. And by the way, there is no data to say that you can't detox a woman during her pregnancy. And I do it all the time. If I'm going to detox mom during pregnancy, I need to know her level of motivation. I need to know her level of self-efficacy. How does she say no? What are her coping skills? I got to know her living environment. I'm not going to know all this. I need a therapist seeing this person to be able to tell me this, okay? Because I don't want to say, okay, we're going to detox you only to have her go back to heroin or fentanyl and do more harm, okay? This is a team effort. And I got to know, can you say no? If you can't say no, you're not a candidate. So I use the beginning of the second trimester. I do not recommend detoxing the first trimester simply because it increases the risk of spontaneous miscarriage, spontaneous abortion. Control studies they're just lacking. There's just not a lot of good studies out there. I reduced the dose 1 to 2 milligrams every 2 weeks, and I've been pretty successful with it. And I collaborate with other healthcare providers, biological, psychological, social, spiritual disorder, okay? Does maternal dose matter? Doesn't matter if I give a woman 24 milligrams of buprenorphine or 2 milligrams of buprenorphine. This will amaze you that there's a lack of consensus on this, but primarily because we were looking at outcomes of neonatal abstinence syndrome, and the rule of thumb is dose is not a predictor of NAS, okay, or neonatal opioid. So some of the studies noted whether you're taking 4 milligrams, 32 milligrams, there's no difference. Well, there's no difference as far as it goes for the first 3 days. I'm not worried about the first 3 days as much as I'm worried about the entire lifetime. And if you're taking an antidepressant, it's going to be worse. Neonatal abstinence syndrome is going to be worse, which means if you're taking CBD, it's going to be worse. Right? And if you look at the fetal genetics, there are specific fetal genetics and enzymes that we're not going to get into that actually can make it worse. I don't have time for that. Bottom line, methadone versus buprenorphine during pregnancy, buprenorphine is the way to go, albeit it's a double-edged sword. If you look at the sudden infant death syndrome studies, you see that people who were moms maintained on methadone, the SIDS deaths were 93%. That's pretty high. But the data is not clean. So what I'm going to tell you is this. I believe that methadone increases the risk of sudden infant death greater than buprenorphine. I'm also going to tell you that confounding variables include smoking, which is definitely going to make it worse. If you're taking methadone and smoking, you definitely increase your risk of sudden infant death by 3.7 times, okay? And of course, everybody should be using safe sleeping guidelines. With buprenorphine, this is a study out of Finland in 2007. They had 66 patients on buprenorphine, pregnant. They had 2 SIDS deaths. Oh my gosh, that's significant, except they come to find out that the 2 SIDS deaths were related to non-compliant moms, which again means looking at when you do look at all these research studies, you've got to dig down and really take a look at what's going on in these studies. They used other opioids, they were using other drugs. So you got 2 moms. All you can say about this is we had 2 moms who were on buprenorphine who relapsed and had SIDS deaths. That's it. That's it. You can't, there's no cause and effect here. We do know that buprenorphine is an agonist-antagonist. What does that mean? It occupies the opiate receptor, but not 100%, and it actually can repel some other opiates. That probably is going to mean less SIDS deaths. Okay. And then when you're assessing your pregnant addict, oftentimes you got a broken family. And if you look at addiction, we're going to focus on addiction just for a second. It's a brain disease, no doubt. Your reward system is hijacked. Your motivation is very high. It's just in the wrong place. Your memory is abnormal. Hippocampus is abnormal. And you have repeated maladaptive behaviors that cause your dorsal striatum, which we talked about earlier, to become hardwired to think that use is normal. Biological, psychological, social, spiritual. A brief look at Maslow's hierarchy, physiological needs, safety needs, and belonging, et cetera, et cetera. As we look at that hierarchy that we all try to climb, at least I do, you see the people who are using opioids are stuck here. She's got to get up and take care of her physiological needs before she does everything else. Doesn't mean she doesn't want to take care of the other stuff. It simply means she can't get off ground zero until she gets the opiates in her body to do it. Okay. So what happens when you're using and you're hijacked, your brain is hijacked on opioids, which means the frontal part of your brain that's responsible for executive functioning is no longer in balance with the emotive part of your brain, which is responsible, the limbic system, if you would, emotion. And when the opioids activate your emotive system, it overrides and dampens your prefrontal cortex. In other words, you think you're doing quite well and you're doing horribly because everything else fades to the back. And what you see in these people, they're self-deluded. They believe it. They think they're invisible. They don't think you can catch them. They justify lying and blaming and projecting because they can't trust you. Oftentimes, they see themselves as victims, and oftentimes they are victims. because their crazy circuits are activated. Nothing's going to change. And when you talk to these people, what you're dealing with is an emotive brain. So here you are, hopefully you're the normal, on the left, and your prefrontal cortex is, your executive function is working, and you can talk maturely to the person. And the yellow part of your brain over there is your emotive part of your brain, and your prefrontal cortex overrides the emotive part of your brain. That's not happening with mom on the right. Her emotive brain has taken over. Her prefrontal cortex is impaired. Okay? And you say, why can't she understand what I'm telling her? I know she's not stupid. She must think I'm stupid. Now you're caught. You just started to project. Am I talking to a child? Yes, you are. You're talking to an adolescent brain. How many times do I have to say this? You know what she's thinking? Why doesn't she understand me? I can't get through to this woman. She keeps saying, she's making things complicated. And then she says, maybe if I just keep saying the same thing, she'll finally figure it out. She won't. Okay. Screening tools in pregnancy, probably useless. None show significant specificity and sensitivity. May make you feel good to do it, but you'd probably just be better off asking, hey, you use drugs? Dangers that opioids pose, again, these women are more likely to die in hospital, 5 times more likely to die in your hospitals. So again, don't forget that people bring stuff in from the outside. Keep the Narcan handy, and I'm not making light of that. Let's look at some of the opioid pain dynamics. I think you saw this earlier, so in the first presentation, I'm not going to get into it a whole lot, except to say that when you start taking opioids, you have a hyperpain response. Okay, a cat rubs up against you and it hurts. Okay, that's called allodonia. You have a hyperpain response. Other people say stub their toe. They say no big deal. You say, oh my gosh, I think my toe is broken. Okay, that's called hyperalgesia. And what it means is that your pain is being amplified because of the opioid you took that screwed up your brain. Okay, the pain's real to you. Post-delivery pain management, if you're on buprenorphine, the good news is that buprenorphine causes less hyperalgesia. Methadone causes more. If mom comes in on methadone, she's definitely going to require more pain medication. IV Tylenol works. A lot of my pregnant ladies I'm telling, ask the anesthesiologist to give you some IV Tylenol. It seems to decrease the post-delivery and post-C-section pain. And if you're going to resume OAT, buprenorphine, resume it as soon as possible. There are different options to deal with pain. I have handouts. I work with the obstetricians. You can stay on the MAT and supplement with IV Tylenol. You can get off of it, take regular opioids, and then get back on it. Here's something I don't like. Okay, the nurse says you need to get up. Hurts too much. You're a mean nurse. You know what that means? I'm reporting you. I'm going to complain. Okay, well, I'll just give you what you want. That sounds pretty crazy, doesn't it? Here's one of the reasons it's crazier. See this pain management tool? This is where pain management tools belong. Pain is not a vital sign, and it's not a reimbursement gauge. If I give you opioids less than 3 days, I minimize your risk for long-term opioid use. This is if you're an addict or not. For every day I give you opioids over 3 days, I'm increasing your risk for developing an opioid dependency. And if you're a pregnant woman and have depression, and I'm giving you opioids, you run 2 times the risk of becoming an addict, okay? Because that's going to relieve your depression some, but it's a hell of a double-edged sword, and you're going to pay for it. I like tramadol for pain, but don't forget tramadol has a low abuse potential, but it has an abuse potential. Okay? So if I'm taking buprenorphine, Suboxone, or Zubzol, should I breastfeed? Yes, you should. There's a very decreased low level of buprenorphine in breast milk. Plus, buprenorphine has to be taken under the tongue, so the baby's swallowing the milk, so there's not going to be a lot of bioavailability. Okay? Matter of fact, only about 1.4% of the maternal dose is even going to get into the kid. So there's no reason not to breastfeed if you're taking buprenorphine. Okay? You may want to time it. We know that buprenorphine peaks at 90 minutes, So either harvest your milk or breastfeed 90 minutes before you take it or 90 minutes after you take it, okay? You can kind of schedule that in. And be sure and monitor your child. You don't want them getting loaded or drowsy. Just monitor and look for developmental milestones. I don't think you're going to see, if mom stops breastfeeding and she's on buprenorphine, I just don't think you're going to see opioid withdrawal. Neonatal abstinence syndromes have been going on since been reported since 1875. Every time there's a new drug introduced, there's going to be NAS. Let's look at this woman. Mitra G, she's 29 years old. She presents for delivery. She's from out of town. Her urine drug screen is negative. She has a history of low back pain. The only medication she's taking are prenatal vitamins. And she says, oh, I take herbal supplements for low back pain, but that's no big deal. The baby gets here, the baby's jittery, has stiff muscles, is sneezing a lot, crying, tearing, not feeding well. Drug screen on the baby is negative. She's in kratom withdrawal. Okay. Kratom withdrawal. Let's talk about kratom. Kratom is in all forms, shapes, and sizes. You can go down to the Circle K and get you some. I don't recommend it. It's from a particular tree, and it's been used for years for pain and diarrhea and opiate withdrawal. Matter of fact, it was an opiate substitute in the early 1800s. Low dosage, you have a stimulant effect. High dosage, you have an opioid effect. You can even get comatose and go into a psychosis with it. Kratom overdose exists. If you've got somebody who's overdosed on kratom, the naloxone spray works. Give it to them. Kratom acts on opioid receptors. It's an opioid. There's no doubt about it. It acts on all of them. It's addictive. When you get off of it, you start to detox. It's not illegal. And I think that the FDA and the EA have failed us on this because there's a lot of political pressure not to control it. And that's ridiculous to me. I think they've really acted inappropriately here. You never know what's in kratom. Salmonella. 37 states reported salmonella infections behind kratom. Heavy metal poisoning, which is going to impair brain development. Nickel and lead are found in it a lot. Opioids, they can be cut with fentanyl. Pesticides are going to be in it. What a surprise. And who knows what else. Okay. Okay, if mom comes in and she's in recovery, you need to have a relapse prevention plan in place. That needs to be negotiated before she goes in hospital. And ideally, well, places like the GRACE program here in Baton Rouge do a great job with this. When you're doing that assessment, don't forget about the epigenetic assessment if dad's been doing dope. And you need to know what happens with mom during pregnancy, what she's been taking, et cetera, et cetera. You may or may not be aware of this. If dad's using opioids, he can actually cause methylation of his opioid mu gene, opioid receptor gene, to the extent that the child that he fathers will inherit a propensity to be an opiate addict. Okay? Nobody uses in a vacuum. Long-term effects of opioid use in pregnancy: visual effects, delayed motor milestones, poor motor coordination. In other words, impairment of your brain function. And if you look at it, look at them. Here's a 2-year-old. These are people who were on, mom was on buprenorphine, Suboxone, or she was on methadone. Now we're looking at her kids who are now 2 years old. We don't see any striking distance in the type of effects, but we see a striking difference, a significant difference in the severity of the effects on women who are on buprenorphine versus methadone. And so we're seeing lower rates of buprenorphine. But what we're seeing still, as you would expect, delayed motor function, delayed social function, delayed language skills, and you may or may not see these eye formations. And the nystagmus, and I see this in my practice a lot, repetitive uncontrolled eye movements. The kids come in, they're 2 years old, and mom's here to see me for the first time, and I look at the 2-year-old kid, and the kid's got rapid uncontrolled eye movements. And when I talk to mom, she says, oh yeah, I took that during pregnancy. And that's kind of what it looks like. You just see that rapid eye movement there. These kids may also have an ability to align both eyes simultaneously. So if you see this in a child, it's a cue to you that this child may have been exposed to opioids during pregnancy, and therefore you need to align this mom with the appropriate resources that can help her address the problems that may present due to neurodevelopmental disorders in the child. All right, hallucinogens. Hang with me, guys. We're almost there. Ecstasy. Yeah, still around. Mostly female, mostly young female users. They're usually single and out there doing the party scene. MDMA causes a decrease in serotonin in mom and increased cortisol or stress hormones in the fetus. What does all that mean? It causes some of the things you would expect to see with amphetamines, because it's a methamphetamine base. And those neurotoxic effects, you can see at 1 year old. Just not a whole lot of data on this. LSD, been around a long time. It hits all the receptors that you would think. It does develop tolerance. Interestingly enough, LSD is stored in the placenta. That's not a good thing. But again, there's just not a whole lot of studies about this. There were some concerns about ocular abnormalities years ago and premature delivery and miscarriages, etc. That was when LSD was legal and they were doing all the studies with Delson. Timothy Leary was doing all the studies with therapeutic mushrooms at the time. Just don't have any data on this, but it's a serotonin agonist, so you're going to have to look for, if somebody tells them I did mushrooms during pregnancy, I'm going to be looking for serotonin effects down the road. Okay, so hopefully I've helped your therapeutic toolbox. I want you to have an index of suspicion, but not be a witch hunter. I want you to realize that secrecy, denial, and misinformation surround this disease, surrounds the patient, and the family also will give you the same type of resistance often. You need to observe the other kids to see how they're developing. This may be a cue that you may be looking for same. You need to understand the difference between substance use and substance use disorder. And to that end, I'm sure that's one of the things you're here for today. So, brief motivational interviewing, we should all know it. Everybody, anybody in the healthcare profession should know how to do brief motivational interview. All right, guys, I've made it. We'll do Q&A right now, and I'll change this before I go into a seizure myself. And is there any Q&A?
First question, are you aware of ACPS current policy as it relates to accepting or reporting of a pregnant mom of using drugs when no other children are in the home and the unborn child has not yet been delivered?
I don't know the answer to that, but I know in Louisiana, if the unborn child hasn't been delivered, it's not a child. I don't know the answer to that. That's what I'm saying.
So far, that's the only question.
Well, good, because I'm getting hoarse up here. Well, I thank you for your attendance. Have a smoke-free day. If you have questions, you have my email. I'll shut it down then.
Thank you, Dr.
Thank you. My pleasure. Appreciate y'all. All right.